Good morning to you all, and welcome to the day 2 of SLCTRIMS 2024. We start off this morning with a lecture on autoimmune encephalitis, and we have the honor and privilege to have Professor Eoin Flanagan, a professor of neurology and chair of the Division of Multiple Sclerosis and Autoimmune Neurology from Mayo Clinic, Minnesota, USA. He will talk to us today on autoimmune encephalitis, diagnosis and misdiagnosis. Over to you, Prof. Flanagan.
Great. Thanks so much. Again, it's a real pleasure to be here again to talk to you today again about today autoimmune encephalitis, focusing on diagnosis and misdiagnosis. These are my disclosures here, which are not too relevant as today it'll be focused mostly on diagnostic aspects of autoimmune encephalitis. So in terms of neural antibody discovery, this is a timeline going from 1960 all the way up to 2021. And what you'll see here is that the discovery of neural antibodies has really increased over time. So initially, the striated muscle antibody was found. The ANA1 or anti-Hu antibody was found in the 1970s. Some of these on the top are antibodies to intracellular targets. And on the bottom, we have antibodies to extracellular targets like the muscle acetylcholine receptor antibody. And around the mid-2000s, with the discovery by Dr. Dalmau of the NMDA receptor antibody, there has been a huge explosion in the number of antibodies associated with autoimmune encephalitis. And you'll see many of these listed here. And again, these have been both to intracellular and to extracellular targets. So we now have many different diagnostic biomarkers available to us that can help with making the diagnosis, although access to some of these antibodies is not widely available. So we did a study in Olmsted County, which is the county where the Mayo Clinic is located in Rochester, Minnesota. And what we did was we were looking at the prevalence of autoimmune encephalitis when compared to infectious encephalitis. And overall, we found that the prevalence was pretty similar. And it was interesting in that we found that there was some differences over time. So when we looked from 1995 to 2005, the incidence of autoimmune encephalitis was low, and then it tripled from 2006 to 2015. And that was mostly driven by new antibody discovery. And over the same time, infectious encephalitis remained fairly static. So the bottom line is that we should be thinking about autoimmune etiologies when a patient presents with encephalitis, as it probably represents an important proportion of cases and it's potentially treatable. So it's important not to miss this category of diagnoses. So how do we recognize autoimmune encephalitis? Well, some patients will have a preceding viral prodrome. We talked a bit about MOG antibody-associated disease yesterday, and that can often have a viral prodrome. We'll talk a bit more later about post-HSV encephalitis. Sometimes you can get an autoimmune phenomenon, particularly with NMDA receptor antibodies. And some patients can have a prodromal weight loss or diarrhea, particularly with the DPPX antibodies. So sometimes it's important to look before the major neurologic symptoms happened, were there any other symptoms happening? The other thing to mention is that with autoimmune encephalitis, the presentation is a bit different to neurodegenerative dementia. It tends to be more subacute, occurring over weeks to months or days, and there tends to be more rapid progression. So if it's in the form of the dementia, it tends to be more rapidly progressive, similar to CJD. Seizures are quite common in autoimmune encephalitis. That's less commonly seen with neurodegenerative etiology, so it's important to recognize that seizures can be common. And then you may have multifocal involvement of the nervous system with central nervous system, peripheral nervous system, neuromuscular junction. It's important as you're thinking about your differential diagnosis when you're examining patients to ask or examine hearing. Hearing can be important for Kelch-like protein 11 antibodies, which can be associated with hearing loss, but also for your differential diagnosis. Some of these patients can have mitochondrial disorders that mimic autoimmune encephalitis, or patients with vasculitis will often have hearing loss. Vision is also an important consideration. It's important to check patients' vision, look in the back of their eyes. As we said yesterday, MOG antibodies can associate with optic neuritis or and with encephalitis, and there may be optic nerve involvement. And then sleep disorders are actually quite common. So, for example, with the IGLON5 antibody, there tends to be very prominent sleep disorders. You can also have narcolepsy cataplexy with MA2 or aquaportin-4 antibodies. Some patients can get laryngospasm in their sleep with ANA2 antibodies. So we sleep for a third of our day, so it's important to ask patients about that when they present. Another thing to note is that it's important to note the past medical history. So if a patient has a history of a cancer, sometimes after that's treated, when the cancer recurs, that can be when a paraneoplastic autoimmune encephalitis begins. And then we'll talk a little bit later about immune checkpoint inhibitor treatments, which may provoke an autoimmune encephalitis. One other thing I'll mention about the approach to the neurologic examination is it's quite useful to try and quantify the deficit when you see a patient if they're well enough to do this. So some patients will come to the outpatient setting with a rapidly progressive dementia or have some sort of encephalopathy, but it's good to quantify on bedside cognitive testing how they're doing, because then you can judge how responsive your immunotherapy was. There are many characteristic clinical syndromes. These are syndromes where there's a high risk of an antibody being positive. Facial-brachial dystonic seizures are one, where patients will get twitching of the side of the face and dystonic posturing of the arm, and sometimes involvement of the leg. That will last a few seconds at a time. You can have opsoclonus myoclonus with ANA2 or ANA1 antibodies. ANA1 antibodies, particularly in children with neuroblastoma. We can have Morvan syndrome. We'll show a video of that. You can have limbic encephalitis, in which there's many different antibodies, and I'll show some examples of that through the talk. In a child, often with ADEM, you want to think about antibodies, particularly the MOG antibody, which will account for about 50%, or aquaportin-4 antibodies, where we see them in about 5%. The syndrome progressive encephalomyelitis rigidity and myoclonus is another syndrome that you can see in patients presenting to hospital, and the one we think about there is GAD65 or glycine receptor antibodies. And then patients can have kind of on the spectrum of autoimmune brain involvement, at least paraneoplastic cerebellar degeneration, for example, with PCA1 or anti-EO antibodies. And then we can have a psychiatric syndrome that progresses to encephalitis in young women. And that's what we think of typically with anti-NMDA receptor encephalitis. So you want to watch out for these classical clinical syndromes. And in that situation, antibody testing is very high yield. I'm just going to see if I can share my sound here. So this was a patient who had Morvan syndrome with insomnia, encephalopathy, hyperhidrosis, but also had peripheral nerve hyperexcitability. And you can see here some of the twitching of the muscles. And had a very active EEG or EMG with changes of neuromyotonia. And this tends to be associated with the Caspr2 autoantibodies. So if they just have peripheral nerve hyperexcitability on its own, it's called Isaac syndrome, and that can be a little bit different. So when we're evaluating autoimmune encephalitis, we will often look at the MRI. And here we can see some examples. We went over many of these yesterday with multifocal white matter lesions within the brain with MOG antibody-associated disease. Of course, with MOG antibody-associated disease, we talked about this novel phenotype with the unilateral cortical encephalitis, sometimes with leptomeningeal enhancement, or we can have involvement in the infratentorial regions with large middle cerebellar peduncle or diffuse brainstem lesions. The classical imaging finding in autoimmune encephalitis is this limbic encephalitis, where you see this T2 hyperintensity, mostly restricted to the mesial temporal lobe. It can be more unilateral, like we see here, more unilateral or bilateral. There's some slight signal abnormality here on the right side, but predominantly this was left-sided. Here we can see involvement. This was a patient I saw with paraneoplastic chorea in the setting of CRIM5 autoantibodies, and you can see these T2 hyperintensities throughout the brainstem here in the setting of a hyperkinetic movement disorder. We can have lesions deep within the brain in the hypothalamus in the setting of MA2 and a narcolepsy cataplexy phenotype. So it's important to look for deep brain signal abnormalities. We can also see similar signal abnormalities with aquaporin 4 antibodies that we talked about yesterday. Your post-gadolinium images can sometimes be helpful. Sometimes you'll see this radial, linear periventricular perivascular enhancement that we see here in this characteristic pattern that we can see with GFAP autoantibodies. We can also see that with sarcoidosis or with some other conditions, so it's not fully pathognomonic, but it should make you think about GFAP antibodies. I'll also mention that it's important to remember that the MRI may be completely normal. For example, with NMDA receptor antibodies, you may have a completely normal MRI. And in fact, the majority of patients will have a normal MRI. And in this situation, the antibodies become particularly important because they can make the diagnosis for you. In patients who present with an encephalopathy, we'll often obtain an EEG. And we're generally looking for epileptiform activity, sharp waves, spikes, subclinical seizures. Oftentimes, these patients will have either generalized or focal slowing. It's important to recognize that the faciobrachial dystonic seizures are very fast and often won't have any EEG correlate. So sometimes these are mislabeled as functional neurologic disorder. And then you can have an extreme delta brush pattern. What we see here is with this slowing with superimposed fast activity. Here we see slow waves and then superimposed fast activity on top. That's pretty typical for the extreme delta brush. It can also be seen in other forms of encephalitis. In patients who present with encephalitis or suspicion for encephalitis, then we'll often do a CSF study and we'll be looking for evidence of inflammation. So this will be an elevated white blood cell count, but also it's important to assess for oligoclonal bands as they may be the only marker of inflammation. We can see these, we know, with multiple sclerosis, but they're often quite common with different forms of autoimmune encephalitis. It's also helpful for us to assess for alternative etiology. So we'll look for infections with herpes simplex virus, PCR. We can look for prion proteins with the RT-QuIC testing. We can do next generation sequencing looking for unusual infections. We can also look under the microscope for cancer cells with CSF cytology, flow cytometry, and then we can look for degenerative biomarkers with Alzheimer's disease biomarkers as outlined here. And then the next step is we can actually test for antibodies in the CSF. And CSF antibodies are going to be the most important in the setting of an suspected autoimmune encephalitis. So how does the antibody testing work? Well, in our laboratory, the mainstay we use is called tissue-based immunofluorescence. So we have a composite of mouse tissue, like is shown here. And then we add the patient's serum or the patient's CSF, and then we add a secondary antibody with an immunofluorescent tag. And we look for binding within the brain. So the normal would be dark green here where there's no staining. And then we can see very bright green here is prominent staining. And this is a patient with NMDA receptor encephalitis with prominent staining in the hippocampus and the cortex. Here we can see CRIM5 staining with staining in the cortex and involving the myenteric plexus. And then here we can see nuclear staining and cytoplasmic staining with, nuclear staining with ANA1 or anti-Hu antibodies. Other laboratories will use immunohistochemistry, which can be used similarly. And this is kind of our mainstay in our laboratory. Then if we see a pattern, like we see the anti-Hu antibody, then we can use a Western blot to confirm that. And having two methods of confirmation gives you a higher specificity. We used to use a lot of immunoprecipitation technique to detect these antibodies, but it's somewhat of a dirty technique and tends to increase the risk of false positivity. So we've been moving away from this technique in our laboratory. There are some laboratories that use cells in culture, so you can grow neurons or you can have astrocytes or oligodendrocytes in culture. And then if you have live cells and you add a patient's sample and then add a secondary immunofluorescence tag, you may see a signal for cell surface antibodies. It will only detect usually cell surface antibodies if the cells are living. And then we have cell-based assays, which is one of our mainstays that we use now. This is an NMDA receptor antibody cell-based assay, and here you can see these are HEC293 kidney cells with NMDA receptors transfected on the surface, and you can see here the binding to these cells, while the background cells serve as a control that don't have NMDA in the surface, and there's no binding to those. This is a fixed cell-based assay. We can also use a live cell-based assay, and we can get a readout using FACS or flow cytometry. So we use this for our MOG antibody, where we look for binding to these cells with the MOG on the surface, like we see here. And we measure this degree of binding compared to the background rate in the cells that don't have MOG on the surface. We can also sometimes use ELISA. So what's the goal of our antibody testing? Well, the number one goal is to help us make a diagnosis. So it's very useful in certain situations where it will tell us what the underlying diagnosis is, but it can also tell us other information. It can tell us what type of cancer the patient might have. For example, if you have an NMDA receptor antibody, then you may have if you're a young female, you may have an underlying teratoma. On the other hand, if you're a smoker and you have ANA1 or anti-HU antibodies, you're likely to have a small cell lung cancer. So it helps guide your cancer search. It can also help you with treatment decisions. We know that certain antibodies respond better to different treatments. For example, GAD65 antibodies in the setting of stiff person syndrome respond well to IVIG. LGI1 antibodies respond much better to corticosteroids, and aquaporin 4 antibodies, for example, respond very well to plasma exchange. It can also tell you about the prognosis, and we'll talk about this. We can divide our antibodies into two different categories, the ones that bind to the cell surface and the ones that bind to the intracellular targets. And the ones that bind to the intracellular targets tend to have a worse prognosis. They don't respond well to immunotherapy, and they're more highly associated with cancer. So if we start off with the cell surface antibodies, this is, for example, our LGI1, our aquaporin 4, our NMDA receptor antibody. These antibodies have the potential to be directly pathogenic. So the antibody can come in here and they can bind the receptor, and that can lead to endocytosis and degradation of the receptor on a global level that leads to dysfunction and symptoms in the patient. Binding can also lead to just dysfunction of the receptor and cause symptoms in that way. It can also recruit in other immune cells with antibody-dependent cellular cytotoxicity, and that can lead to damage. You can also get secondary complement activation. For example, this is quite prominent with aquaporin 4 antibodies, and has turned out to be a mechanism of treating aquaporin 4 antibody positive NMOSD. These antibodies to the cell surface markers tend to have a lower risk of cancer, and they tend to respond well to treatment. So there is a risk of cancer, like with NMDA receptor antibodies, but it tends to be less than 50%. And they tend to respond well, particularly to antibody-depleting treatments. So treatments like plasma exchange or antibody-neutralizing treatments, I suppose, like IVIG, or treatments that prevent the production of antibodies like targeting CD20 on B cells with medications like rituximab. On the other hand, antibodies to intracellular targets are a little bit different. So these are not directly pathogenic because the antibodies can't pass the cell membrane to target the cytoplasmic and nuclear antigens that are the target of these. And it's thought that these are markers of a paraneoplastic phenomenon, and these peptides get upregulated on MHC class 1, and they target the cell for destruction by cytotoxic T lymphocytes. And this leads to this being quite a destructive process, and we often see a high risk of cancer. So for example, with the PCA1 or anti-EO antibodies, you're going to have a 90% risk of cancer. And they tend not to respond as well to these treatments. So in general, they tend to have a poor response to treatment and an overall poor prognosis. So it's important to remember those two different categories, but there are some exceptions, but overall, that is a good way to think about the different categories of antibodies. So what about autoimmune encephalitis in novel settings? Well, we're starting to see this more and more, and this is good news if you're an autoimmune neurologist because it's keeping us in business, but we're understanding that even up to a quarter of patients after herpes simplex virus encephalitis can have a secondary autoimmune phenomenon. We don't know the exact mechanism of this, whether it's because it's quite a destructive virus and there's many antigens released, and then that leads to a secondary autoimmune phenomenon. And many of these are positive for NMDA receptor autoantibodies. So if you have a patient who you treat with acyclovir for herpes simplex virus encephalitis, and then they have a recurrence and the virus is gone, then you might want to think about using some immunotherapy and maybe checking for neural antibodies. We can also see neurologic autoimmunity in the setting of immune checkpoint inhibitors. This is putting the accelerator on the immune system, and obviously you can have immune-related adverse events, and some of these can include an autoimmune type encephalitis, and indeed can be positive for neural antibodies. We've also seen autoimmune encephalitis in the setting of post-transplant. We know that with transplant, we use mostly T-cell depleting medications, and perhaps it's that balance between your T and your B cells. If you get imbalance between your T and B cells, you may provoke some autoimmunity, and some of these have responded well to, again, antibody depleting agents. So this has been seen with NMDA receptor antibodies and some other antibodies, AMPA receptor antibodies, and others. I'll just briefly mention the diagnostic criteria from autoimmune encephalitis, which were published by Grouse and Dalmau in 2016. And they require you to have an initial possible diagnosis of autoimmune encephalitis, followed by you then, for this, you must have a subacute onset of rapid progression of deficits over the course of 3 months with altered mental status or psychiatric symptoms. And then you must have one of the following: either focal CNS findings, seizures, CSF pleocytosis, MRI features of encephalitis, and reasonable exclusion of other causes. And then if you meet these criteria for possible autoimmune encephalitis, then you go into this somewhat complicated algorithm where you'll determine which category of autoimmune encephalitis you fall into. And then if you go through the whole algorithm and you don't fall anywhere, then you should reconsider the diagnosis. So what about autoimmune encephalitis misdiagnosis, which I'll focus on over the next few minutes? We know that mimics are more common than autoimmune encephalitis. So autoimmune encephalitis is overall quite rare, even though we highlighted that we've had many discoveries in this field. But if you think about it, toxic metabolic is going to be more common. So what I tell my residents is, if you have a 90-year-old female who comes into the emergency department, has a history of mild cognitive impairment and comes in confused, you want to check them for a UTI. Don't check them for neural antibodies up front. Psychiatric disease is much more common. So depression with psychosis, schizophrenia, bipolar disorder are all going to be far more common than autoimmune encephalitis. And indeed, studies have suggested that autoimmune encephalitis accounts for about 1 to 2% of new onset psychosis. So there are many other things to consider ahead of it. Also, neurodegenerative conditions like Alzheimer's disease, Lewy body disease are going to be much more common. Infectious etiologies, again, we said were similar. And then patients can have brain fog, and they may not have a true encephalopathy, but that's also quite common in the setting of medication toxicity, chronic migraine, chronic pain, polypharmacy, etc. And there's been limited data on patients who initially received a diagnosis of autoimmune encephalitis, but that was an incorrect diagnosis, and they later were diagnosed with something else. But we at least at the Mayo Clinic, and I don't know about other places around the world, but we encounter this reasonably frequently in our clinics, where patients are labeled with autoimmune encephalitis, but in fact they have something else. And there are risks to misdiagnosis. So if you immunosuppress the patient, you may increase the risk of infection, and then you're delaying the diagnosis and the treatment of the actual disease. And that might be important. For example, with thiamine deficiency, if you develop acute confusion, you may have a window where you can replete thiamine. And if you miss that window, you may lead to permanent damage. So I'm going to focus in on a little study that we did. This was a multi-center study involving the Mayo Clinic, the University of Oxford, University of Utah, UCSF, UT Southwestern, and Washington University St. Louis. And we put together our experience with autoimmune encephalitis. So we had a total of 107 patients who were misdiagnosed as autoimmune encephalitis, and the median delay to diagnosis was 16 months. And we had a combination of different conditions. Some of these conditions were what I term kind of non-neurologic. They're not our typical neurologic conditions. So that was a functional disorder, was often mislabeled as autoimmune encephalitis, primary psychiatric disease like schizophrenia, or non-encephalopathy could be misdiagnosed as autoimmune encephalitis in the setting of brain fog, post-COVID, fibromyalgia, polypharmacy. But then we also had true neurologic conditions like neurodegenerative dementias, for example, Creutzfeldt-Jakob disease, Lewy body disease, Alzheimer's disease. Neoplasms, temporal lobe gliomas particularly, were problematic here. And then other conditions that have waxing and waning signal abnormalities like MELAS. If you give them steroids at the time of their MELAS episode, this is going to, the natural history is it's going to get better. So you may think the steroids is helping it, and then the patient may present again with a subsequent episode. Here's some examples from our study. We found this was a patient with a temporal lobe glioma, mimicking autoimmune encephalitis. This was a patient with lymphoma with enhancing lesions and signal abnormality within the splenium of the corpus callosum. This patient had HIV-associated leukoencephalopathy, mimicking autoimmune. This was a patient with MELAS here. And then we had some neurodegenerative conditions with Alzheimer's disease and Creutzfeldt-Jakob disease. And I will say, autoimmune encephalitis diagnosis is actually quite challenging. And I have made errors. I've misdiagnosed patients. So I think it's a challenging field, and it's something that we need to be on the lookout for. And some of the most common reasons for misdiagnosis in this study was overinterpretation of a non-specific antibody, particularly thyroid peroxidase antibodies or TPO antibodies. A misinterpretation of functional symptoms or non-specific and brain fog type symptoms as true neurologic encephalopathy. Or imaging that overlap, like those temporal lobe gliomas. And sometimes there can be reluctance to accept a psychiatric diagnosis amongst patients or parents with children with psychiatric disease, where autoimmune encephalitis is sometimes a more palatable diagnosis, given there can be some stigma with the psychiatric disorders, but it's important we recognize and treat them accordingly. So that can sometimes be a challenge. The most common elevated antibodies in our study that were problematic were TPO antibodies, GAD65 at low positive levels. GAD65 antibodies at high titer or in CSF are useful, but at low titer, it's quite common in the general population, as we see this with patients with autoimmune type 2 diabetes. The voltage-gated potassium channel is not a very useful antibody because now we have LGI1 and Caspr2 antibodies, so this one can also be seen as a false positive. And then serum NMDA receptor antibodies that are positive in serum but negative in CSF is a problem. And then the selected others, sometimes testing by Western blot alone for some of these antibodies is quite problematic. And some of these other antibodies can also be problematic that are outlined here. We did find a few CSF antibodies with NMDA. We found some where it was NMDA cell-based assay alone. Without the tissue immunofluorescence, we can sometimes see it with other conditions, and we don't know exactly why this is. It's still a very good test, but it's not perfect, and sometimes there can be challenges. But mostly, the issue was with the serum autoantibodies. Most of these patients received immunosuppressive treatment, and many of them had side effects, including steroid-related side effects like psychosis, avascular necrosis of the hip, heart failure. There's also risk of infections. So this was a study that we published in JAMA Neurology in 2022, and there was an accompanying editorial by Dr. Dalmau and Grouse, just highlighting that about autoimmune encephalitis and misdiagnosis and misconceptions. In terms of red flags, from this study, an insidious onset of symptoms rather than a subacute or acute onset is a red flag. If you have no inflammation on CSF and a completely normal MRI, you at least want to consider whether it could be something else. It's important not to over-rely on these non-specific autoantibody results. And then many of these patients did not fulfill that initial criteria for possible autoimmune encephalitis, usually because they were insidious in onset or their CSF and MRI were normal, or many of them had even normal neuropsychological testing, which would be a big red flag for autoimmune encephalitis. But there are some caveats. Sometimes you can see absence of inflammation in the elderly in cases that don't fulfill criteria, and usually the clinical features will help you. Just to mention, TPO antibodies are found in 20% of elderly adults. So these are not a good marker of autoimmune encephalitis because they're found so frequently in the general population, including at high titer. And there are some other antibodies with our older generation techniques that we've actually removed from our antibody panel because they're too problematic. There's some examples here. And then sometimes the titers can help you. We talked about MOG antibodies. When it's high titer, it's quite useful. GAD65 is the same, but low titers are problematic. And sometimes in the laboratory, we can use dilutions to help us determine the risk. There was a nice follow-on study from Dr. Titulaer and his group, showing again the wide variety of different conditions that can be misdiagnosed or mimicking autoimmune encephalitis. And again, sometimes T2 hyperintensity in the mesial temporal lobe in the setting of a glioma was missed, and then they also saw some problems with some of these low positive antibodies. I'll leave you with two additional clinical pearls here. Here is an example of gyriform restricted diffusion. Here you can see this very bright restricted diffusion here in a gyriform pattern with associated ADC darkening. And this is most typical of status epilepticus or seizure-related signal abnormality, and favors that if you see this, because sometimes they'll have T2 hyperintensity here in the FLAIR image, but if you see this restricted diffusion, think more that it might be seizure-related and it may not be autoimmune-related. There are some genetic syndromes. The RAN BP2, so acute necrotizing encephalopathy, can mimic autoimmune encephalopathy, and often you have prominent deep gray matter involvement. So if we conclude today, I'll just mention that we'll talk about the clinical syndromes that patients can have. This was the patient with LGI1 antibodies and facial-brachial dystonic seizures. We talked about the MRI with unilateral encephalitis. We talked about the CSF being helpful to make a diagnosis, to test for those antibodies, but also to look for inflammation and look for mimickers. We talked about the EEG. Sometimes the extreme delta brush pattern can help suggest NMDA receptor encephalitis. We talked about our mainstay of antibody testing being this tissue immunofluorescence space, and then confirmation with a cell-based assay is what we most commonly use, this being an example of NMDA receptor antibodies. We talked about the two different categories of antibodies that bind to cell surface targets, like we can see here, that tend to have a good prognosis and tend to be less associated with cancer. And then we have antibodies to intracellular targets in the cytoplasm and nucleus, like PCA1 or ANA1 antibodies, anti-HU, that tend to have a poor prognosis and very frequent cancer association. Finally, we talked about some red flags for the autoimmune encephalitis, including an insidious onset, a non-specific antibody, particularly TPO antibodies. And then we talked about looking at your MRI. Again, here you can see an example. This was a temporal lobe glioma. Early on, this mimicked autoimmune encephalitis. Later on, it became more exophytic and expansile, and it was clear this was not related. And then this is, if you see progressive atrophy only of the temporal lobes, you're going to be thinking more about a neurodegenerative etiology. Also, don't forget that with NMDA receptor antibodies, your MRI may be completely normal in the majority of patients indeed. And in this situation, the antibody testing becomes quite useful. So I'll stop there, and I'll just acknowledge many of my collaborators who are involved in this study, including the many centers that I mentioned earlier. And this is some of the other centers and some of the other people who are involved in this very nice collaborative international multi-center study that I think just highlights some of the issues that we should be considering in our clinics and in our hospitals when we come across patients with encephalopathy or suspected encephalitis. So I'll stop there. I'll stop my share, and I'll be happy to take any questions if there's time.
Thank you, Professor Flanagan. Thank you for that very comprehensive talk. In interest of time, I think we could take about just one question. If I may ask, we get a lot of referrals for autoimmune encephalitis in our cases because people are more and more aware about it and worried about it. Would you recommend doing antibody testing in patients who are having monosymptomatic presentations like only psychosis or any abnormal behavior or just speech disorders? Do you think we should test those patients or not test those patients?
Yeah. It's hard, you know, I think you have to use your clinical judgment. So, for example, if a patient has a long history of psychiatric disease and then presents with a new episode of psychosis on the background of many different psychiatric diseases, that might be a patient where you would not do antibody testing. On the other hand, if it was a 20-year-old female who presents with new onset psychosis and no other risk factors, then it might be a patient where you want to test for NMDA receptor antibodies. So I think you have to kind of weigh up your judgment in that situation. and see what the testing is showing. You know, a lot of patients with autoimmune encephalitis will have a CSF pleocytosis, so I wouldn't be afraid to do a CSF in some of those patients who have new onset psychosis and potentially test for autoantibodies, because it may give you a clue. So a lot of times psychiatrists are reluctant to do CSF studies, but for us in neurology, CSF is like a blood test, and I think we should have a low threshold if there are not a lot of red flags. But then it's important to recognize if the testing comes back negative, the likelihood is still very low that if it's a new onset psychosis, that it is indeed autoimmune encephalitis. So you want to think about other things and not go down the route of immunotherapy when everything comes back negative.
Thanks a lot. I think we are behind time. So once again, let us show our appreciation to Professor Flanagan in our usual way.
Thanks so much.
Next talk will be, because we missed the first talk, it will be Professor Hartung who will do the next session. So may I invite the chairpersons for the next talk.
Next speaker is Professor Hans Peter Hartung from Germany. He'll speak to us on fluid phase biomarkers in multiple sclerosis. So over to you, Prof.
Thank you very much, Chairs. Good morning. I have to apologize that I was the reason for somehow disrupting the sequence of talks. Let me just assure you it was not due to the toxic effect of alcohol profusely offered at last night's beautiful festivity. So my task is to review the role of fluid phase or body fluid biomarkers in multiple sclerosis. Of course, you know, biomarkers come in different flavors: imaging biomarkers, molecular biomarkers, and I restrict the discussion to body fluid biomarkers, which may serve different functions. They aid in the diagnosis and differential diagnosis within the spectrum of inflammatory demyelinating CNS disorders, aid in immunophenotyping clinical variants, detect disease activity, and I think this is particularly relevant in the context of PIRA and the type of granularity you use in your tools to find disease activity or progression, predict and monitor disease progression, and then stratify, individualize, and monitor disease-modifying therapies. Now, this liquid biopsy can be done on different materials, of course, on the cerebrospinal fluid, blood, serum or plasma, urine, and tear fluid. But of course, the most accessible and practical is a collection of blood, which allows you to sequentially assess the various aspects of MS as they are mirrored in fluid phase biomarkers. Now, of course, the real breakthrough came when Zetterberg and colleagues in Gothenburg introduced the SIMWA, single molecular assay technology, that would allow to detect with high sensitivity molecules, including neurofilaments in peripheral blood. As you know, it's been studied in the CSF for many years. Axel Petzold, in actual fact, was one of the champions. And we continue to look also in the CSF in certain circumstances, but really practical has it become by introduction of this specific methodology. As you know, neurofilaments are limited to the neuronal cytoskeleton, They are released into the interstitial fluid by axonal injury, neurodegeneration. Initially, as I alluded to, studied in the CSF, while the current focus, for obvious reasons, is on levels in blood. There are type 4 intermediate filaments with a diameter of 10 nanometer. You see the different four subunits, which are also here displayed in graphic fashion, and the intermediate neurofilament light is shown on the top. Now, to summarize the research that has been done over the past years, first of all, take a look in the upper right corner of the number of publications that started to explode, and now there's no week passing by without at least one paper looking at SNFL in any kind of context, both within the realm of multiple sclerosis and beyond. These are three relatively recent reviews, and they center based on the collectively adduced evidence around the question whether it's the first true blood-based biomarker of multiple sclerosis. And coming back to the roles that fluid-fed biomarkers may play, if you contrast that to the questions that are imminent and pressing in multiple sclerosis, well, you can detect inflammatory activity, you can detect disease progression, you can monitor treatment response, and you can prognosticate, and hence there are a number of functions of clinical import and results you can derive from studying them. However, and this is a caveat, I mentioned we have 100-300 papers per week. It's not disease or physiology specific. You see it in aging, cardiovascular disorders, PNS damage, for example, Guillain-Barré syndrome. You have levels in blood that are much higher than in multiple sclerosis, brain trauma, pregnancy, body mass index. So a whole lot of damage to the central nervous system gives rise to increased levels of neurofilament light. This is one of the earlier papers looking at SNFL levels in the blood. For one, in panel A, you can clearly appreciate the correlation with age, and so you have, when interpreting levels, also make reference to the age. So as we age, there's more NFL spilled over into the CSF and then into peripheral blood. You also see here one of then a series of publications looking at the various causes of multiple sclerosis and how that is reflected in the levels of SNFL. And you see it's elevated both in relapsing and in the progressive forms, in the latter even more so compared to healthy controls. There seems to be a correlation with EDSS that you can appreciate from graph C. Now, if one then focuses one's interest on progressive MS and studies SNFL, again, as I mentioned, these levels are not markedly different. In relapsing MS, provided you exclude relapses. SNFL are higher in secondary versus primary progressive MS. They are increased in active versus not active progressive MS. and they've been linked to inflammatory activity and correlated with their expression on MRI. It's also been shown several times that baseline SNFL are predictive of future disability, brain and spinal cord atrophy. However, I think it's still fair, or the jury is still out, that these are derived from cohort studies. So whether it's possible to, and within a very tight research context, whether it's possible at this moment in time, whether it's already prime time for including them in the management of any given individual patient, I think we need to see. But that's obviously what we eventually want. Now, another very important tool of these fluid-phase biomarkers is to monitor treatment response, and there have been several publications looking at the response of initially elevated SNFL to DMT administration. And you see here from the EXPAND and FREEDOMS Transforms trials of fingolimod that indeed there is a decrease in the response to S1PR modulators. In secondary progressive MS, high serum NFL is also associated with low SDMT scores and greater brain volume loss at 2 years. So a predictive value of determining this particular biomarker. This is just providing more detail gathered from the various trials with fingolimod. Here is another DMT, ocrelizumab, and what ocrelizumab, both in the relapsing trials, the OPERA 1 and 2, and in the PPMS trial, oratorio, does to SNF levels. In people with relapsing MS, ocrelizumab reduced NFL levels into healthy donor levels by week 96, consistent with its significant impact on reducing acute disease activity and progression. In patients with PPMS, there was a greater reduction in NFL with ocrelizumab compared to placebo, and even modest NFL reduction in this population translated into significant impact on disease progression, particularly if you extended the observation period. And persistently elevated NFL levels at week 48 following initiation of ocrelizumab therapy was associated with future disability progression in both people with relapsing and progressive multiple sclerosis. And only a minority, some 20% or so of relapsing MS patients did have persistently high NFL levels on ocrelizumab. And on the group level, NFL is reduced into the healthy donor range in the vast majority of patients by week 96. Now there's quite a literature on SNFL in progressive MS. I don't want to really go through all of them. I'd just like to refer you to this very nice review paper by Kapoor and colleagues published some years ago. One interesting aspect was to correlate SNFL levels with cognitive decline here in progressive MS, and it was found that SNFL, but not SGFAP, I will talk about this in a minute or so, was associated with concurrent or future SDMT. So much for SNFL. I think it's fair to summarize that it's now the most robust biomarker and obviously also the most widely studied in multiple sclerosis. Let's now turn to another biomarker that has more recently come into focus, and this is glial fibrillary acidic protein, or GFAP in short. It's a type 3 intermediate filament of 50 kD molecular weight, and it has multiple fundamental roles in the workings of astrocytes. Astrocytes, as you know, are critically important in forming and maintaining structural integrity of the blood-brain barrier, synaptic function, astroglial metabolism. GFAP is elevated with astrocyte activation and astroglial proliferation and scarring. GFAP is the signature intermediate filament of astrocytes. So you see here some of the molecular data, 432 amino acids coded by chromosome 17 can form homodimers and heterodimers. It's expressed in mature astrocytes both in gray and white matter, in various locations, cerebellum, subventricular, subgranular zones, in the retinal Muller cells. And utilizing this highly sensitive assay methodology, SIMOA, it can be measured in blood. In MS, several groups have found sGFAP to be elevated when compared to healthy controls, non-inflammatory neurological disorders. Increased levels appear to correlate with disability, MRI lesion load, SNFL, and brain volume loss. This is from a very nice recent review by Abdel Haq, published in Nature Reviews Neurology. It's also important to note that levels correlate with age, irrespective of any disease, and there's an increase of some 1.5% per year. Levels are decreased with BMI of 1.19%, and it's increased in females by a moderate proportion. About half of patients with worsening progressive MS have shown to harbor elevated levels of sGFAP when compared to stable multiple sclerosis. Higher baseline sGFAP associated with accelerated gray matter atrophy. You see the metrics there, but not with white matter loss. sGFAP was unchanged during disease exacerbation versus remission. I'd just like to briefly talk about this single center cross-sectional exploratory study of some 130 patients with MS, the vast majority being relapsing, remitting, but also included were 18 PPMS patients, and a multivariate analysis in these progressive patients showed higher sGFAP, but not SNFL versus RMS. And in this particular study, sGFAP versus SNFL correlated with white matter lesion load was inversely correlated with various local and global brain volumes and volume loss. It's also been studied as a marker of treatment response, in this instance siponimod, a comparative study against placebo, and you could observe a reduction in increased levels with siponimod treatment, whereas those patients randomized to receive placebo had an increase in sGFAP. Let me now leave SNFL and sGFAP and come to another biomarker of importance, and you heard it already discussed by Professor Montalban with the perspective of this also finding its way in the 2023 revisions of the McDonald criteria. It's the potential roles of kappa-free light chains in CSF. You remember that antibodies are made of heavy and light chains, and there is evidence that in multiple sclerosis, intrathecal kappa-free light chains are markedly increased. One often expresses them in terms of an index relating it to serum levels and taking into account the distribution between CSF and serum. Now, kappa-free light chains in body fluids are not bound and are under certain conditions produced in excess intrathecally, as I mentioned already. There have been a number of very useful reviews published recently discussing the potential varied roles of kappa-free light chains in the CSF. And I will talk a little bit as I go on these roles. As a potential diagnostic marker, it's been studied, and this is a paper. These are various papers looking at the diagnostic value of kappa-free light chain, also versus oligoclonal bands in the CSF. And kappa-free light chains have been shown to differentiate CIS MS from other neurological diseases and controls. It could present a valid, easier to do and rater-independent alternative to oligoclonal banding detection. So there are various ways to determine intrathecal production of these kappa-free light chains using the index, that what most people do, reflecting also the percentage of intrathecal production, CSF concentration, and then various ways of coercions. And this is a paper that performed a meta-analysis on this topic. There's quite some literature now emerging on kappa-free light chains. You see here that there are similar levels if OCBs are negative, regardless of the clinical status, whether it's patients with CIS that stay CIS or those that convert to clinically definite multiple sclerosis. Now, this is a summary showing graphs from several studies, a single center study of CIS and MS patients, some 370 patients. You can see the increased levels of CSF kappa-free light chains and also a perspective, a prognostic value that those patients harboring in their CSF elevated kappa-free light chain have a higher chance to convert to definite multiple sclerosis. There's a multi-center study with more patients in the same cohorts in the single or similar cohorts in the single center study in, again, MS and CIS patients. This is from Arambide's brain paper from Barcelona, looking at the risk for a second attack of patients presented initially with CIS, and that was very similar between certain cutoff levels of kappa-free light chains. The highest risk for dissemination in space and time was demonstrated for a KFLC of around 5.9. And various cutoffs and specificities and comparisons to OCB were reported recently in N2, and it's worthwhile having a look at this paper. So, prior to the 2017 revision of the McDonald criteria, data coming from the Barcelona group made a strong argument for reintroducing oligoclonal bands into the criteria. There were many reasons why they previously were left out, not the least of which the lack of experience determining OCBs on the other side of the Atlantic. But then, the very convincing data, particularly on the prognostic use of OCBs and kappa-free light chains, led to inclusion, and the kappa-free light chains in all likelihood, as we heard from Professor Montalban yesterday, will be introduced in the 2023 version of the McDonald criteria. And this is graphically shown on the right, sort of as a consequence of the studies reported in the spring paper. Now, apart from diagnostic value, I just picked some papers, and there is a role for prognosis, as I mentioned. This paper on the right demonstrates that kappa-free light chain index predicts disease course in clinically and radiologically isolated syndromes. Those with increased chains marked by the bluish lines clearly have a higher risk, a significantly higher risk to turn into definite MS from CIS. Now finally, if I may, I will briefly talk about chitinase 3 like protein 1, another a marker that has been studied for many years now. I don't necessarily see that it will be included in the McDonald criteria. It's a protein of multiple cellular sources, 40 kD glycoprotein, hydrolyzes glycopolymer chitin. It's involved in inflammation, tissue remodeling, cell growth, proliferation, and angiogenesis. It's detectable in CSF and less reliably so in blood, higher in MS versus CIS versus healthy controls, higher in converting than non-converting CIS, higher in PPMS than RRMS and SPMS, and apparently associated with long-term disability in progressive multiple sclerosis. I put down the two recent papers upon which these statements are made. This is a meta-analysis looking at CHI3L1 levels in CSF elevated across the studies in PMS versus RMS. And the Barcelona group, who really started in 2010, Manuel Comabella, intense investigations into this molecule, suggests that it has a role as a biomarker in multiple sclerosis. Now, another development is to not use one single biomarker, but compute biomarker composites and scores that in recent papers have shown to be more robust and may provide more comprehensive information. I don't have time to go into it, but there are scores based on NFL and GFAP markers that have been proposed to be able to differentiate between relapsing, remitting, and progressive multiple sclerosis. Finally, arachidonic acid metabolites, particularly oxygenase derivatives, have been shown to be increased in progressive multiple sclerosis versus other disease types, and one should follow this one observation, I think, more closely. It's interesting. It seems to be particularly important in PPMS, and this is from this paper showing the lipoxygenase derivative elevated by mass spectroscopy in multiple sclerosis. So I tried to go through quite an extensive list of markers that have been studied. SNFL is best studied, well established, assessed by SIMOA. There are age reference values. It's elevated in PPMS versus SPMS versus healthy controls, associated with disability progression, brain and spinal cord atrophy, responsive to treatment. That has been shown for siponimod, ocrelizumab, more recently also Darin, basically for all effective DMTs. It's also promising SGFRP, as I mentioned, questionable chitinase 3-like protein 1. Composite biomarkers may provide more information and be particularly relevant, as I earlier mentioned, when one tries to increase granularity in determining true PIRA. Now, I think in the future we will look at molecular signatures, capitalizing on bioinformatics, on AI, proteomic, metabolomic studies that will provide us with a more detailed and more extensive view of the other underlying pathobiology of multiple sclerosis. And with this, I'd like to end. Thank you very much for bearing with me.
Thank you very much, Professor Hartung, for that very informative presentation. And I think we can allow one question from the audience.
Hans Peter, thank you so much for the excellent overview of the existing data of various body fluid markers in MS. My question is about the high level of serum GFAP in MS. You convincingly showed that high level of serum GFAP is associated with future disability or reflecting treatment response. So that may mean that GFAP or the astrocytes may be functionally abnormal or may be damaged or destroyed in that phase of MS, but alternatively, in the chronic phase of demyelinating lesions, astrogliosis occurs. So as a turnover of large number of astrocytes in astrogliosis may also contribute to the high level of serum GFAP. So could you tell us more about the pathological background of high level of serum GFAP in MS?
Thank you, Katsuri. You, of course, as always, posed the very pertinent question. I mean, one wouldn't have a priori assumed that you would come across these high levels. I think we are only beginning to understand the exact pathogenic role of astrocytes in multiple sclerosis or chronic demyelination. If you look at the normal physiology, it's understandable that with astrocyte activation occurring in a highly inflammatory microenvironment in the CNS, you get levels up, but also if as collateral damage occurs towards astrocytes, there is the chance that you can pick up this particular astrocytic protein in peripheral blood. I'm not aware of any longitudinal studies over extended periods of time that would further elucidate the role of astrocytes. But there is now quite a substantial body of evidence, for example, that astrocyte function or dysfunction greatly impacts on the capacity of the CNS to remyelinate. So I think we need to take a closer look at astrocytes, and Quintana's lab is heavily investing in this.
Thank you.
You're welcome.
Any more?
I join Kazuo in congratulating for your really very comprehensive and informative lecture. The fact that in progressive MS we don't see the same expected level of increase of neurofilaments compared to relapsing remitting phase is in some way telling us that the amount of tissue destruction in progressive MS tend to be less than the amount of tissue destruction that you have in the relapsing remitting phase. That's really a bit surprising. But is there any data where it has been compared in progressive MS the changes of neurofilaments in those with a quite rapid accumulation of disability and those with a very slow accumulation? Because even in progressive MS there is a lot of inter-individual variability. So it could be interesting to know if there is any relationship.
Thank you very much.
Data?
Thank you very much, Giancarlo. Yes, it's exactly what you suspected, that within the spectrum of progressive MS, there is this group with at least intermittently periods of high activity, and that translates into transiently higher SNFL levels, even in a group that on a whole, if you look across the board of progressive MS, has lower levels. So it's a very dynamic situation, I think,
So
which also necessitates then longitudinal assessment. I mean, as I mentioned, I don't think it's yet prime time to include in the day-to-day management. There are, I think, tempting arguments to do that, particularly if one wants to be absolutely sure about true PIRA versus not so true PIRA, other than monitoring treatment, and perhaps raising the red flag that should prompt a further study of this particular patient.
So in the interest of time, I think we should conclude the session now. And thank you, Professor Hartung, once again for that very interesting talk. So let me now invite the chairpersons of the next session.
Good morning. Welcome to the Symposium 3, Neuroradiology of Demyelinating Disorders. The first lecture is about pathophysiology of multiple sclerosis, dissected by MRI. I would like to invite Professor Daniel Ontaneda from USA to start the symposium. Thank you.
All right, so thank you very much, first of all, for the kind invitation to present today to Professor Senanyake and also to Professor Fujihara for the connection. I was asked today to talk about pathophysiology of multiple sclerosis dissected by MRI. I am sorry I cannot attend in person. I missed the festivities that Professor Hartung was referring to previously, but hope to join at a future date in person. These are the disclosures for my talk that do not have any major relevance to what I'm going to be discussing today, but I did want to mention and acknowledge that slides presented incorporate some material that was presented at the Barcelona revisions of the McDonald Criteria 2023, including sections on CVS paramagnetic rim lesions by individuals including G1O, Danny Reich, and Christina Granziera. So today I'm going to be talking about how we use MRI and how we can use MRI to identify pathological substrates of multiple sclerosis. Start with a short introduction, then I will start to talk about the central vein sign, then chronic active lesions, specifically how we image them using MRI in the form of paramagnetic rim lesions and slowly expanding lesions, and then finally end with some conclusions. As many of you know, multiple sclerosis is a condition in which MRI is used quite heavily. I would venture to say that MRI is the most utilized biomarker in clinical practice today. MRI can be acquired in minutes. It's a non-invasive technique and is sensitive to detect pathology both in the brain and the spinal cord. And as probably was highlighted earlier or yesterday in Professor Montalban's talk, it forms the backbone of the current diagnostic criteria and how we reach the diagnosis of MS in a prompt manner. And as you know, MRI can be used both as a prognostic marker and also to document treatment response and make treatment decisions. There are, however, some limitations with MRI. One of those limitations is that there still is significant delays in times to reach a diagnosis of MS, making refinement and simplification of criteria, specifically MRI criteria, somewhat important. And we know that the diagnostic criteria have become more sensitive over time, and that may have come at the price of decreased specificity. And although conventional MRI is sensitive for MS, in many ways it's non-specific. And it sometimes reveals very little about individual lesions and the tissue destruction in lesions. That is, when we look at an MRI, a T2 lesion is a T2 lesion is a T2 lesion. However, the variation that there might be in axonal loss in those individual lesions varies substantially, and that's not something we quantify on MRI. And while new gadolinium-enhancing lesions serve as ideal phase 2 outcomes and have aided in the development of multiple disease-modifying medications for relapsing multiple sclerosis, there is no such tool utilizing MRI to predict a response in phase 2 in relation to phase 3 outcomes, which is a sorely needed unmet need. And with this background, I will start talking about two areas that I have done some work in and that I think would be important to share. The first is the central vein sign. The central vein is not new by any means. These are pathological descriptions of the central vein by Dawson in 1916, demonstrating that demyelinating lesions occur surrounding central vascular tissue. The idea for many years has been that inflammatory cells might migrate from a central vascular component, typically a vein, into surrounding white matter and produce the demyelinating lesions that we know from multiple sclerosis. And we know that we can view these lesions on MRI. This was first done using what was previously termed venography, but has gone through several adaptations. And this is a slide that demonstrates that central veins can be identified on several field strengths, including 7 Tesla, 3 Tesla, and 1.5 Tesla. And you can see there is a clear dark signal in the middle of lesions when they are cut in their longitudinal axis, taking the appearance of what some have termed a coffee bean, and when slashed in their short axis, might take on the appearance of what would call a coffee bean. As you can see, the lesions are probably most conspicuous. The presence of central vein is most conspicuous at 7T. However, you can also notice that at 1.5T, those lesions are still visible. I think one key theme when one is trying to utilize a new diagnostic biomarker, one thing that is ideal is to provide a very clear definition of what that is. And this was done, certainly. This is the central vein sign consensus paper from the North American Imaging MS Cooperative, to which my center belongs. And in this paper, we laid out what was the radiological definition of a central vein. We said a central vein should exhibit the following properties. It's a thin, hypointense line or small hyperintense dot, that it can be visualized in at least 2 perpendicular planes, that it has the vein itself has a small apparent diameter, that it runs partially or entirely through the lesion, and that we're calling it central, so it has to go through the middle of the vein. But we also recognize that we also should include some exclusion criteria for these lesions. That is, lesions that are less than 3 millimeters cannot count. They typically would not count either for the diagnostic criteria when lesions are confluent, that is, lesions that are touching each other, when a lesion potentially has multiple veins, and when lesions are poorly visible. So we've defined what we call an individual lesion as a central vein, and the next thing we need to do is, when do we call an individual scan positive for the central vein? And this has been done in many different ways. Here I am listing the 3 most common ways of determining if a scan is positive for the central vein. The first and probably most robust method is the 40% threshold. One counts the total number of lesions, the total number of CVS positive lesions divided by the total number of CVS positive plus CVS negative lesions. And if that percentage is greater than 40%, if greater than 40% of the lesions contain a central vein, it's considered a positive study for central vein. In Select 3, one takes 3 lesions that are pre-selected on FLAIR and then looks at the T2 star or SWI images. And this could be considered positive if one considers 2 out of 3 lesions or 2 out of 3 lesions. Select 3 star, which is one just simply counts the presence of up to 3 lesions that have a central vein. So any patient with at least 3 lesions with a central vein is considered positive. And then similarly, Select 6, where one counts up to 6 lesions being positive for MS. One can see here that that 40% threshold does a pretty good job in distinguishing non-MS cases, where they're typically less than 40%, and cases that are MS. But perhaps I think the best way to look at this data is to summarize graphically what it looks like. So this is a very interesting figure. It basically shows the proportion of conditions associated with white matter lesions that contain central veins. As you can see on the x-axis here is the percentage of lesions that have a central vein. The blue triangles are studies of patients with multiple sclerosis, and you can see the vast majority of those will be at least above the 60% threshold. You can see early studies that were predominantly done at 7T. The percentages were a little bit higher. The percentages come down a little bit on 3T MRI, but certainly remain above that 50% threshold. Conversely, the red circles that you see are other mimicking conditions: incidental findings, NMO, MOGAD, headache, vascular changes, migraine, dementia, small vessel disease. And one can see pretty clearly that although there is some variability in the proportion of lesions, the majority of those conditions will have fewer than 40% lesions with central vein. Now, this has been demonstrated quite robustly in multiple studies. And here I'm showing a meta-analysis. So we have gone from looking at 1 or 2 individual studies with central vein to looking at meta-analysis with a very large number of studies. And you can see here the proportion of CVS lesions across all these 35 studies was approximately 73% for patients with MS. If you image patients at 1.5T or take only studies at 1.5T, the percentage of central vein lesions is 58%. At 3T, it's 74%, jumps up to 82% in 7T. And if one uses a very dedicated sequence to look at the central vein, namely T2 star echoplanar imagery and T2 star EPI, that number is also quite high, 82%. Important to note that even at 1.5 T, the optimal cutoff of 40% is well above what one would expect. And therefore, even at 1.5 T, we think there is good diagnostic accuracy. The pooled specificity for a diagnosis of multiple sclerosis across these studies was 92%, and the pool sensitivity was 95%. Similar meta-analysis looking at quantitative synthesis of some of the similar studies, a total of 21 studies, shows very here that the optimal cutoff is 45% with a pooled specificity of 97% and a pooled specificity of 98%. Once again, demonstrating ideal diagnostic accuracy, and one can see a very similar drop in the percentage of central veins as one moves from 7T to 1.5 T, however, above the 40% range. What about the abbreviated methods or counting up to 3 or 6 lesions? This is a Magnum's multicenter study conducted across 8 different sites, a total of 606 patients, looked at SELECT3 with a sensitivity of 61.9% and a specificity of 89.0%. A 35% threshold demonstrated a sensitivity of 68% and a specificity of 92. So one could see here that SELECT3 approached the diagnostic performance of a specific threshold. Similarly, in a subset of those patients who were imaged with a dedicated sequence for central vein, namely the 3D T2 star EPI, one can see that had a sensitivity of 93 and a specificity of 73.3%, and one can look at the ROC curves demonstrating the robust diagnostic accuracy of this method. A similar study of a multicenter application of abbreviated CVS that was conducted prospectively. The difference between this study and previous studies was that this study recruited patients who had not yet had an established diagnosis of MS. These were patients who presented to an MS center for the question of a diagnosis. And the comparison group wasn't not having MS, were individuals who were not diagnosed with MS at that encounter. Therefore, this kind of imitates a little bit better what we see in clinical practice. SELECT3 had a sensitivity of 81% and a specificity of 68%. SELECT6, that is counting up to 6 lesions, had a sensitivity of 65% and a specificity of 98%, once again demonstrating good diagnostic performance despite these patients being slightly earlier in their disease. A similar study exclusively using T2 star EPI, which is the dedicated sequence in 4 studies, total of 51 patients that followed patients over 7 to 31 months, showed similar very high sensitivity for SELECT3, 93%, and specificity of 92%. SELECT6, counting 6 lesions, sensitivity of 89%, and specificity of 92%. I wanted to highlight this study. This is a study that I am currently running called the CAVS-MS study. It's a study that's funded by the National Institutes of Health, and we have studied 420 patients across 10 sites using the dedicated T2 star EPI data. These patients were recruited and will be followed for a total of 2 years. And what we did in this analysis was look at the baseline data. So without follow-up, but just when the patients arrived at these MS centers for a diagnosis, what was the sensitivity and specificity of SELECT3 and SELECT6 among patients with a clinically isolated sigil. We found that the sensitivity was approximately 78% and specificity of 63%, and sensitivity of 59% with specificity of 75%. So once again, even in these very early patients presenting to an MS center, we see reasonable diagnostic accuracy. One of the questions that we've asked ourselves over and over is, well, how was the comparative diagnostic performance of the central vein sign to other diagnostic tests that have been used for multiple sclerosis for many years? And a very clear example of this are oligoclonal bands. We heard in the previous talk mention of CSF biomarkers. And here we talk about the concordance of CVS with oligoclonal bands. This was a study called Decisive, study conducted, multi-center study conducted in the United Kingdom by Professor Nikos Evangelo, consented a total of 113 patients and diagnosed MS patients in a total of 77, diagnosis of CIS in 12 patients, and alternate diagnosis in 8 patients. And the question was, well, how frequently did oligoclonal bands versus central vein detect multiple sclerosis? Oligoclonal bands correctly diagnosed MS in 84% of patients, while central vein diagnosed MS correctly in 91% of patients. There was overall good agreement between oligoclonal bands and SELECT6 CVS of 81%. We did a similar analysis in the CAVS pilot study. This was a total of 53 patients who had had CSF fluids. And we found that the sensitivity of oligoclonal bands was 75% and a specificity of 76%. And the sensitivity of SELECT6 using central vein sign was 71% with a higher specificity at 0.86%. This is important because it demonstrates that in both these studies, there was good agreement, approximately 81% in this study as well, between CVS and oligoclonal bands. And the diagnostic performance of CVS in many cases was even better than oligoclonal bands, a test that is routinely used to confirm a diagnosis of MS. So conclusions regarding the CVS reflects demyelination as a pathological process that occurs around venous structures. The central vein can be seen using 1.5, 3T, and 7T across imaging sequences already in practice, including susceptibility-weighted images, and soon T2-star EPI, which is already being developed both by Siemens and Philips to be commercially available on scanners across the world. The CVS has good diagnostic properties and may be used as an adjunct tool in the diagnosis of MS. And finally, the CVS may also help identify monitoring MRIs of MS patients if new lesions are indeed related to myelination or not. Next, I will be talking about the second way we think we can use MRI to provide more specific diagnostic utility in the form of chronic active lesions. I'm sure most of you are familiar with the concept of a chronic active lesion. This is a figure taken from Bruce Trapp's publication. And one can see normally myelinated tissue here with the central vein structure in the middle, massive influx of inflammatory cells in the setting of an acute lesion, and then what we call a chronic active lesion, which is a core of demyelination surrounded by a rim of activated microglial cells that stain typically against MHC2, and we think are lesions that slowly expand over time. Finally, those lesions can, what we call, burn out over time and just show basically scar tissue or gliosis without an inflammatory component, without a chronic inflammatory component. This was demonstrated on pathology as well. As you can see, the orange bars here is what they call smoldering lesions, which are chronic active lesions. And you can see they occur with greater frequency in progressive patients and with a slightly lower frequency in monophasic or relapsing patients. And this led to the idea that this might be somewhat of a late phenomenon in the disease. And I will show you some data that perhaps suggests that might not be true. So we talk about this history of a lesion of multiple sclerosis that starts as an acute lesion, massive influx of inflammatory cells. Those inflammatory cells then certainly tend to go or move to the periphery of the lesion. A necrotic, central core of demyelination occurs. And when that demyelination core is surrounded by myelin positive cells, some of them microglia that are chewing up myelin, some of them containing iron, is what we classify as a chronic active lesion. Typically at this stage, the blood-brain barrier is closed, which is different from the acute lesion. And then over time, we see those lesions leave their rim, the microglial activation disappears, and you're left with simply a chronic silent lesion, which is basically just a gliotic lesion, closed blood-brain barrier, no demyelination, no inflammatory cells. And this takes me to the concept of a smoldering lesion. So on pathology, it's sometimes hard to determine how things change longitudinally because you, in general, have just one cut of time, and that's the time of death. However, one can glean some information on what the behavior of those lesions were at the time of death, and one can intuit if that lesion was a lesion that was slowly expanding over time. And precisely one can see here, this is a PLP stain, and this is an HLA stain. You can see a band of cells here at the periphery of the demyelinated core that stains positive for CD68, stains positive for HLA, MHC2 class cells. And you can see that in a variable proportion of those MHC2 class cells, you can see the presence of myelin inside those macrophages. This leads us to believe that those macrophages are actually chewing up myelin and are advancing, causing that lesion to be what we would consider smoldering and also expanding over time. So going back to MRI, the question is, how can we visualize these chronic active lesions using imaging? Well, I am giving a talk specifically on MRI, and therefore I have left out PET, but using MRI, there's two principal ways in which we can visualize chronic active lesions. One is the term slowly expanding lesions, and the other term is paramagnetic rim lesions. Slowly expanding lesions require imaging over several time points, at least 3. It's not pathologically specific, other than knowing that those lesions are expanding. So we really don't know much more than just the fact that those lesions are getting larger over time. It's not likely to be available clinically currently, but it is easy to conduct an imaging setting, and it's easy actually to conduct in retrospective data sets. So a lot of data has been produced on slowly expanding lesions. Conversely, paramagnetic rim lesions need acquisition of special sequences, but can be acquired just on a single MRI, which is certainly an advantage. It demonstrates the presence of activated microglia and iron. It also can become clinically available as it utilizes the same types of sequences that we are utilizing to image central vein. I will start by describing slowly expanding lesions. So slowly expanding lesions exploit MRI to interrogate lesions that have this chronic expansion over time, creates an imaging biomarker of what we think is ongoing inflammation with associated demyelination at the lesion edge in what we think are chronic active lesions. One key caveat is that these lesions cannot be equated with just enlarging T2 lesions. These lesions, in order to be determined to be slowly expanding, have to evolve slowly. That is, they cannot expand rapidly, and they have to do so constantly. Also, lesions have to evolve concentrically. That is, a lesion cannot just expand on one side of the lesion, they have to expand concentrically, not focal expansion. And in order to determine this, we utilize both T1 and T2 weighted images. This is a paper published by Elliott in 2019, and I also referenced the work by Nakamura, which is the one that first utilized Jacobian integration for image analysis of brain tissue in multiple sclerosis. And the Jacobian method is basically what this method uses. One uses 2 different time points of, in this case, T1 MRIs. One conducts essentially linear registration of those MRIs, and then nonlinear transformation to equate how the local expansion of individual voxels is occurring within each lesion. A Jacobian map is basically processed on that tissue, and then one can see areas of expansion and areas of reduction on that Jacobian integration map. One then takes what one considers the map of the size of the lesions. One then takes the map of the Jacobian determinants of those lesions, and then one can set higher limits and lower limits of what one considers the expansion to be in percentages, and then one can identify the subset of lesions that are considered slowly expanding. In order to explain this a little bit further, because it's a somewhat complicated mathematical process, I'm just going to show here what we mean when we talk about constancy and concentricity. So you have 2 lesions here. What you see in the dashed line is basically a best fit linear expansion, and one here has a lesion that is changing in its mean expansion percentage over time. And therefore, some of these will be farther or closer. In this case, all the time points are very close to that z-score of constancy. That means that lesion is constantly and slowly expanding over time. Versus you can see an example here where actually a lesion is initially decreasing in size, then actually decreases even further. And overall, this lesion cannot be said to have a good z-score constancy for that linear expansion over time. And therefore, this lesion would not be considered a slowly expanding lesion. Similarly, here you have a lesion that very concentrically is changing around its center, as you can see, versus this lesion, which is actually just changing in one direction. So it's just one pole of that lesion that's changing, not the entire lesion. And so in order for a lesion to be considered a slowly expanding lesion, there has to be that constancy and that concentricity that we talk about. So let's look at some data that shows us how frequent slowly expanding lesion numbers are and the volumes. This is from the randomized controlled trials of ocrelizumab. And one can see that patients on average had 4.6 slowly expanding lesions in the RMS group and 6.3 in the PPMS group, similar to the data that had been suggested before, that it is a somewhat later phenomenon. And similarly here, our pooled OPERA 1 and 2 studies showed the mean volume detected as 1,223 cubic millimeters compared to 1,838 in primary progressive MS patients. What does slowly expanding lesions tell us about prognosis? Well, in this study of 135 relapsing remitting patients, it clearly demonstrated that EDSS worsening was predicted by slowly expanding lesion volume, but not by total lesion volume and not by brain atrophy. And there was actually a 5.5 greater risk of confirmed disability progression for each increase in each log volume unit of slowly expanding lesions. This can be demonstrated also by looking at the MRI characteristics of lesions. When looking at T1 hypointensity here, one can see lesions that are non-cells typically do not tend to lose. If anything, in this study, they gain T1. They did not become darker on T1, that is, they became lighter on T1, versus definite cell lesions and possible cell lesions both actually became darker on T1 over time, indicating possibly greater tissue destruction. Similarly, this study by Preciosa and colleagues, 52 patients with relapsing remitting MS, showed that EDSS worsening at 9 years was associated with greater than 4 slowly expanding lesions, a higher proportion of lesions defined as cells, and lower baseline MTR of cell lesions. And you can see here, these are the different components that predicted EDSS worsening. As we all know, EDSS baseline score is one of the biggest predictors, but you can see baseline MTR and greater than 4 number of cells were among the features that were most driving the worsening of the EDSS. In terms of treatment effect, one can see very clearly that when one looks at clinical trials that examine potentially mechanisms of compartmentalized inflammation, for example, using BTKI inhibition, in this case with evobrutinib, one can see clearly an effect of the medication, a dose-related reduction in decreasing cell volume with higher doses, suggesting that this medication might have a role on affecting cells. Similarly, one can also see from data from ocrelizumab clinical trial and primary progressive MS comparing placebo with ocrelizumab, there was a statistically significant effect in all cell lesions as well. This is data that we looked at with a medication called ibutylast, which is a phosphodiesterase inhibitor, which was studied in a phase 2 trial. And it basically showed that lesions had a reduction in cell volumes when you compared placebo versus ibutylast. So ibutylast produced a 23% reduction in slowly expanding lesion volume, but interestingly did not have any effect on new or enlarging T2 lesions themselves, suggesting that there might be some selectivity of ibutylast for this mechanism. Next, I will talk about paramagnetic rim lesions. These are lesions that we can identify taking advantage of the fact that iron co-localized with microglia in these chronic active lesions show susceptibility. When one images with a susceptibility weighted sequence such as SWY or T2 star, acquisition times are clinically feasible, and post-processing can also derive different measures, including phase and quantitative susceptibility mapping, to identify these PRLs. These are examples of very clear PRLs, white matter lesions on T2 star that show this band of what we think is iron within microglia. Similar to what we did with the central vein, this is a paper hot off the press, just published 5 days ago. It's the North American Imaging and MS Consensus Statement on Chronic Active Lesions. And we got together to discuss this approximately 2 years ago. And we determined what the features of a paramagnetic rim lesion was, which is a discrete rim with paramagnetic properties on susceptibility sensitive MRI that is present at greater than 1.52 Tesla and continues through at least 2/3 of the outer edge of the lesion. The rim co-localizes with the edge of all or part of the lesion core that is hyperintense on T2. And the rim has to be discernible in at least 2 consecutive slices on a T2 acquisition, a T2D acquisition, or in 2 orthogonal planes and 3D acquisitions. The features of the core is that it has to be T2 hyperintense. It cannot enhance on T1 post-contrast imaging because then it would just be an active lesion, not a chronic active lesion. We exclude lesions that have veins running along the side that might mimic a paramagnetic rim. And then we also listed a number of red flags, including very small paramagnetic rim structures, a small core, rim thicknesses that's very thin, which is sometimes hard to see. Also lesions that show a magnetic dipole effect, which is basically just an artifact. And we had demonstrated that chronic active lesions typically occur more in progressive patients. But when one looks at the central vein in MS or calves in MS population, which was an early population, we looked at the presence of paramagnetic rims. And to our surprise, we found that 80% of patients diagnosed with multiple sclerosis had a central vein. And the specificity had a paramagnetic, at least one paramagnetic rim. The specificity of paramagnetic rim was 88% with an accuracy of 84%. So this demonstrates that paramagnetic rims perhaps do happen also early on in the disease process. Further evidence to that effect shows the presence of paramagnetic rim lesions in radiologically isolated syndromes, with 61% of patients showing greater than one paramagnetic rim lesion. Certainly, one can also examine the co-localization of paramagnetic rim lesions with oligoclonal bands, and one can see that in patients who have greater than 2 oligoclonal bands, the number of patients who had no pearls was 72.5% versus 93.5% in individuals who had at least one rim or above. Also, a very recent paper that was published just in 2024 by the Swiss group in approximately 600 patients with multiple sclerosis demonstrated that paramagnetic rim lesions was more common in progressive MS than in relapsing remitting MS, that if one looks at the cohort in terms of stability as determined by PIRA, one can find that patients who had PIRA had higher number of paramagnetic rim lesions in the entire cohort, and certainly also in the relapsing remitting cohort, indicating that paramagnetic rim lesions and chronic active lesions are at play in disability accumulation in MS and also in relapsing remitting MS relatively early on in the disease. So this is kind of the final concept of how we think about chronic active lesions and multiple sclerosis at this time. We have two methods, slowly expanding lesions and paramagnetic rim lesions. There's probably some overlap between these two. We think that the lesions that are both paramagnetic rim lesions and slowly expanding lesions, or these expanding paramagnetic rim lesions, are probably the ones that have the greatest tissue destruction and perhaps are the ones that we should be focusing on. Conclusions in terms of chronic active lesions is that they can be identified on MRI as either paramagnetic rim lesions or slowly expanding lesions. Slowly expanding lesions are associated with worse disease course and demonstrate treatment effects in randomized clinical trials. And paramagnetic rim lesions are less common, but still can be used as a diagnostic biomarker with high specificity for MS. They are associated with worse prognosis, and in PIRA status, they are also associated, and they may represent a potential outcome for phase 2 trials. A small word on the 2023 revisions of the McDonald criteria that were already talked about this morning, but I just wanted to highlight the fact that in the proposed revisions, the addition of CVS and pearls as optional tools is important in certain situations. With this, I would like to conclude that MRI is a useful tool for prognosis and treatment monitoring. Pathologically specific biomarker of the disease, such as central vein and paramagnetic rim lesions, can be used to both improve the diagnosis and treatment monitoring. Future iterations of the diagnostic criteria will utilize more specific diagnostic biomarkers of the disease. And we hope that a fully biomarker diagnosis of MS without the need for complicated clinical criteria might be achievable in the near future, and clinical trials will inclusively use pathologically specific MRI biomarkers, such as rim lesions and slowly expanding lesions. I'd like to thank the funders of our work, the National Institutes of Health, the National Multiple Sclerosis Society, and Race to Erase MS, as well as several of the colleagues that have made this work possible. Thank you for your attention, and happy to take questions at midnight in Cleveland. Thank you.
Thank you, Professor Ontaneda, for that informative lecture. And since the time is going, is there one question? Yeah, we have one question.
Hi, Daniel, Giancarlo speaking. Great lecture as always. I have a couple of questions. When we see a dissociation between slowly expanding lesion and paramagnetic rim lesion, do we need to think that the pathophysiological mechanisms that are leading the two conditions are in some way at least partially different, that's really a very important point. And second is, are there any longitudinal studies that have examined if the evolution of PRL lesions and the evolution of small expanding lesions, when they are the same lesion, they behave differently?
Yeah, so excellent questions, Professor Comey. I think the first question on if the two different type of imaging biomarkers of chronic active lesions represent different pathology is still an unanswered question. We have some pathological data on slowly expanding lesions that we've identified in individuals who have actually gone on to autopsy in our brain donation program. And we find that the majority of lesions that are slowly expanding actually do show some form of microglial activation at the rim. It could be a question of also the percentage of microglia that actually have iron. So one can imagine, individual lesions where there is not a high density of myelin in those activated microglia, and therefore it's less likely that those are going to demonstrate a paramagnetic rim lesion, but they might still continue to be slowly expanding. So somewhat unanswered question, but my instinct tells me that they're probably similar in the pathological process which underlies them. I think one has to be a little bit careful because what is determined as a cell is somewhat arbitrary. So the lower percentage and the higher percentage is basically set by us, by a standard. And I think that standard has to be set pathologically. So we're going to need larger data sets to do that from the pathology side point, but I think we can do that. And I think when you do that, I think you're going to notice that rim lesions and slowly expanding lesions probably coalesce and become a little bit more, become basically closer to each other. The second question in relation to if there's longitudinal studies comparing the two, it is very clear that longitudinal studies are present for both. So the NIH has a cohort of paramagnetic rim lesions. The half-life for those lesions is about somewhere between 6 and 8 years. The idea is that these lesions over time lose their rims. So the rim is not necessarily a constant process. And one would imagine that as they lose their rim, they also will eventually lose that slow expansion that they have. A similar analysis has not been done that I'm aware of with slowly expanding lesions, mainly because a lot of the analysis of slowly expanding lesions has been done in clinical trials, and the timeline you have is the timeline you've used to define if a lesion is slowly expanding. Now, a very interesting study would be to take more longitudinal data sets and determine how lesions enter or exit an SCL status over time. To my knowledge, that has not been done yet, but I know that several groups are currently working.
Okay. It's my pleasure to introduce our next speaker in the symposia, Professor Darin Okuda. He's from Southwest Medical Center, Dallas. He's going to talk to us about a new understanding in MS and immunospectrum disorders via 3D conformational MRI measures. Over to you, Professor Okuda.
Thank you very much. I'm going to try to share my screen here. Dan, great to see you. Professor Comey, great to see you. Kazuo is likely in the audience as well, so I hope everyone's doing well. For me, I think it's around 11:30 p.m., so I'm going to try my best to make sense in the time that I have in 25 minutes and take a different stance and show you what my group has been working on. I lead a program on neuroinnovation. We do fairly crazy things. We develop hardware, software, we create manufacturing methods. One of our projects involved developing a wheelless wheelchair. Turns out the wheel is very hard to replace. Here are some of my disclosures, and what's meaningful here is that some of the data you'll see will fall under patents that I currently have or pending patents. So just to make you all aware of that. And I'm going to start here because a lot of what I'm going to show is visual. And our eyes are very interesting because we see the world in a variety of different ways, and everyone sees it very differently. And here you'll see 8 works of art, and only one represents an authentic Picasso piece. And the question is here, which one is the authentic piece? And you may look at all of these images and start to think about Picasso's different art periods, or what colors are used or present, what looks like a typical Picasso or not. So select the one that you think is the authentic piece. And I feel as if the majority of the audience will actually get this correct. So it's actually this piece here called Asleep that has a value near $40 million. It was painted in 1932 during Picasso's neoclassicism period. The rest of the images you see here, I actually created using AI and varying descriptors, natural language descriptors to generate some of these images, and then of course to modify them, which was a massive challenge. And the reason why I'm showing this is because our work has been centered around the radiologically isolated syndrome. And a beneficial consequence of this work has been providing some degree of legitimacy as to whether or not people can have lesions in their brain and not have symptoms. And it led us to look at all of the events that lead up to a given first lesion that leads to tissue injury, and then ultimately, if the right risk factors are present or the right genetic background, people may evolve to a given diagnosis of multiple sclerosis. And as you all have seen, we've had 2 recent randomized controlled trials that have demonstrated the benefit of early treatment. And so I've thought about MS in a different way. In one, focus more on art in terms of, are there things that we can learn from lesions that we see? Because we may not be getting the entire story from these 2-dimensional forced perspective views on imaging. You're given one image, it's static, it has no topography to it, it's just a flat image. And we may be able to manipulate it in 3-dimensional view, or what's called orthographic view, but principally it's like an X-ray where it's just a flat 2-dimensional picture. And so I've outlined my talk in the following ways, in 4 distinct chapters, starting with visual perspectives. And I'll show you how our eyes really can trick us, and why perhaps automated techniques should be leveraged when we look at MRI data. And then show you some work from our group involving 3-dimensional conformational measures. So it's really studying 3-dimensional shape, structure, surface texture, curvature. So it's taking routine MRI data, but looking at them in their actual form in 3D. And then show you the results from one of our projects involving NMOSD, and then briefly talk about future opportunities. So I thought I'd start here, focusing on distance, location, shades, colors, and have you look at a number of things that may allow you to somewhat think about what you're seeing in the future. So we've all seen pictures online where the timing of the photo is just perfect. And the mistake that we make visually is a result, really, of the perspective that's offered to you. So here you see a picture, a photo, and you see a given hand on this woman's left shoulder. It's actually her friend that's holding her, and not this guy in this white shirt. And so the picture makes it seem as such, but it's really not him. Here's a picture of Barack Obama with a rainbow coming out of his hand. You'll have other examples where there could be a given object in front of someone, so not necessarily a group of individuals together, but a book, a tool, a plant that leads to this 2-dimensional error. And then, of course, other more dynamic pictures. And so here, the person that's being carried is not the woman in the black blouse, actually. So she has jeans on. It's her friend who apparently won Miss Popular 2012 that's being held up by the both of them. So our eyes constantly play tricks on us, and there's a reason for that. And I'm going to do my best to explain why that may actually be. Now, everyone sees a triangle here, or they should, and everyone sees a red dot. And I can almost guarantee that everyone in the room feels as if that red dot is closer to the tip than it is the base. And that's how I see it as well. In real life, it's exactly in the center of that triangle. Please email me if you want to see this picture and use a ruler and measure it, but it's exactly in the center. So for some odd reason, we just see it this way. Now, everyone sees two gray boxes, and these gray boxes have the same shade of gray. And human beings really are terrible at discerning shades. We are better at shapes, but shades we are not. And this is work from a 3-time TED international speaker, Bo Lotto, who I've been working with in an effort to unravel some of the mysteries of what we see on MRI, but in a different way. And what's interesting here is that if you place different backgrounds around those same two gray boxes, you'll get a different appreciation of the gray box. So now one appears lighter and the other appears darker. It's because of what's surrounding it, or the colors that surround it. Well, here's the interesting thing. So let's contextualize those two shades of gray in those boxes, and let's put them into rooms. And so this is not a trick. You have the same shades and the same two boxes that I showed you earlier placed in a room. Now, if we turn the lights on, you may have a different appreciation of those boxes. Now, the one on the left seems very white. The image on the right, for the box on the left, it seems very dark. And nothing really has changed. All I've done is I've changed the scenario for you, where now you have to make sense of what you see. And your brain forces you to make sense of what you see. But I will tell you that the shades of gray for those boxes are exactly the same. Now, many years ago, I've worked with Dr. Adelson from MIT, and I love to show this video. I showed it last year, and I'll show it briefly again. Really, in this panel here, in your upper left, you'll see a given shade of gray that's similar to this panel here. Not super impressive, but if I were to tell you that where this green cylinder is in the bottom left, that A is the exact shade of B, you would not believe me. And it's actually true. So this is also not a given camera trick. It is an abbreviated video that shows you live on how our eyes really can trick us and why gray, shades of gray, etc., are at times confusing for us to somewhat discern. And why does this all matter? It matters because when we look at MRI scans, we live in a world between black and white principally. And so our group also has been looking at other ways of looking at MRI scans. Is there a way to introduce color to allow for what you see clinically to be more meaningful? This is a desert landscape that I created using AI. It doesn't exist in the world. It's just a mirror image of itself. And let me show you a few slides ahead because I want to make sure everyone realizes that I'm not trying to trick you. So I'm going to show you at the end this mirror image of an MRI scan, and then a desert landscape. We're going to change the color, and then this is where I'll start, is this desert landscape. Your job, and this is very tough because I'm going to have you do this for 30 seconds, and it's tough in a 25-minute talk to actually pull this off, but there's a gray circle in the center there. What I want all of you to do is do not fix your eyes when I move it to the green and the red slide that follows this. You're going to stare at this gray circle for 30 seconds. I'm going to show you. You're going to keep your eyes fixed on it when the screen is green and red. And I'm going to show you this desert landscape again. And I want to see what you all experience with that. So stare at this center this gray circle here, and do your best to keep your eyes focused there. And what I'm really doing now is it's an effort to retrain what you see, and you can actually enhance given sensitivities of colors depending on which colors you use. So our group is trying to do this to see if we colorize lesions on MRI scans, do they look and can you get a different feel and a different appreciation of what you see? So keep your eyes fixed there. We're going to transition over to the desert landscape. So keeping your eyes in this gray circle here on this next slide, what do you all see? And the hope is that you actually see a vast difference between the two different sides because your brain has been primed with green and red. And it may also alter this image here, which is your standard MRI scans in the standard world we live in when it comes to gray and white. Your eyes should adjust back in a couple of slides, but it may actually be affected as we even move on. So now you have a lesion here, and how do we select that by hand? What is a manual edit? And is there a risk if we apply a manual edit? And my answer is yes. And we've done experiments where we've had people select what they think is the proper isolation of a given lesion, only to find that a computer is very smart because you could use a variety of different conditions. It could allow for a given selection only if neighboring voxels are of this intensity, etc. So a lot of conditional probabilities can be introduced, which is just phenomenal when you're trying to isolate lesions as rapidly and as accurately as you possibly can. So we've applied the techniques to multiple sclerosis, focusing on a variety of things. Lesions to start, dating back to 2016, and then more recently, anatomical structures that are normal, that are impacted by disease. And when we talk about three-dimensional conformational measures, these are what we're looking at. We're looking at different shapes, we're looking at different textures or surface changes, surface curvatures. Our working glioblastoma multiforme looks at structure or changes in structure over time based on these methods. And what's really great in the context of volume change is that when you do a three-dimensional conformational volume assessment, it can tell you exactly where tissue is changing on a given structure. So not just that volume is going up or going down, but that distinct regions have actually changed. And this is all acquired just with a 5-minute MP-RAGE or a flare if we're looking at lesions, a 3D flare or a 3D T2, depending on what structure we want to look at. So pre and post GAD, we're able to apply the same techniques, using the same software and a suite of softwares that we've actually designed to do a variety of things, working with people who are just fantastic in applied math. So many years ago, we looked at just the dynamic changes of lesions, and they change a lot, which is very surprising. And one of the things that we wanted to do was to come up with a system that enabled us to provide better education to patients, knowing how dynamic changes to lesions could be. I'll show you one given example. So here you see a single lesion from 2 MRI time points, and this is a sequence without a gap. It is a 1 millimeter cut, essentially, is what you see. And what's really great here is that from time point 1 to time point 2, you don't see much change. And if I showed you other components of the MRI itself, you would also see that it looks the same. And this is how it was read by the neuroradiologist, and that there was no change over time. And here in the gold mesh is time point 1. And in solid blue, you'll see the lesion in time point 2. So there's been a volume contraction. There's been a displacement in where its positioning originally was, and a deformation with respect to its shape. And this is why central vessels aren't always central, is because the lesions change over time too. And what Dan showed, where there's asymmetric growth, our data suggests that at times what that represents is a coalescing of lesions coming together in between time points. So going back to this same lesion, knowing that it has gotten smaller over time, how much smaller do you think it's actually gotten? Now, it looks the same, and we're telling patients everything is stable. How wonderful would it be to tell them that your MRI is not stable? The lesions have actually gone down in size over time. Now, naturally, they could go back up too, because there is a given sense of a dynamic flux. But in this particular instance, we're really not seeing the benefits that are there. And this lesion has actually gone down by almost 49%, which is just tremendous. So our eyes fool us. And how we actually quantify what we see is really dependent upon math and computer science. And they're really eloquent ways for us to, I think, really quantify lesions in a different way. In clinical trials, we look at the outcome of new and or newly enlarging T2 lesions. But we never use, well, number one, everyone has a different definition of what an enlarging T2 lesion is. But we never use the inverse definition within a clinical trial. We never say, here are the lesions that have gotten smaller, the inverse definition of what we use for newly enlarging T2 lesions. And how wonderful would that be? I mean, especially when you have medications like ibutylast or BTK inhibitors, et cetera, anti-CD40 ligand, RIPK1 compounds. It's just, these are things that we should start to consider in the future, because I think the things that we've been looking at, I think we've really missed a number of things. And lesions do change a lot. And how do we make sense of one new T2 lesion being present, but 7 getting smaller, and getting smaller by not just by 9%, but getting smaller by 30%? It's hard for me to kind of make sense of what that really could mean. Is that really reflective of disease advancement? Yes, but it could be also, it could mean something else. Now, predicting how a lesion will behave many years later, 10 years, I think is really the holy grail. And so our group looks at different surface textures, different shapes, curvatures that could inform on a given greater degree of persistent T1 hypointensity later on in life. And it just suggests that perhaps individuals may need more aggressive therapy based on these data. And towards the end of my talk, I'll show you one slide that kind of links all of this together. So in having this technology, one of the questions we wanted to ask was, is there selective vulnerability in the central nervous system? Because historically in our field, those who have been Black or African American have really been described as having a more aggressive disease course, when in fact, their disease course may have been the result of key social determinants of health, right? They may not have had equitable access to care, to treatments as compared to other groups. And this has been reported ever since I've been involved really in MS. And so we wanted to take a look to see if there are vast differences between those who are of European ancestry and those who weren't. And we looked at the given rates of volume change at the brainstem, but also at the medulla and upper cervical spinal cord. And really the strength of this study was that we included a number of people, and nearly 30% had 3 to 6 MRI time points. So you needed at least 2 MRI time points to really be included. And we had a great split between race and ethnicities. And what's really important to point out here is that these people had EDSS scores of 0 for those that were included. And what we identified, or I'm sorry, what we tried to measure were some of our latest techniques looking at surface texture by assessing the number of triangles that are present. If you're trying to recreate an object, everything is comprised of triangles. In the 3D world, you create a given sculpture using triangles. The more complex the sculpture is, the more triangles are needed to create that given sculpture versus, say, a given box. It doesn't take very many triangles to create a given simple object with not much character on its surface. And we use curvature measures and also studied volumes at the brainstem and cervical spinal cord. And here's what we found. We found that there is a difference between those who are Black or African American and those who are of European ancestry. And even if you were to take the stance that social determinants of health were the key drivers for why people who are Black or African American did worse, then everything should have been worse in that group. And that's not what we saw. So those people who were white actually had greater changes in volume at the medulla and upper cervical spinal cord. So through just a brain MRI scan, because we have an expanded field of view that captures the upper cervical spinal cord, we can actually study down to C2, which is great without having to do another sequence. And it stays relatively stable regardless of head position, which is great. Those who are Black or African American did have a variety of changes within the pons, the surface texture changes that informs on really the degree of integrity, although we did not have histopathological data to confirm that. And then surface curvature measures also, which is telling of the same. Does that surface change in any way? And does it change in a way where it appears as if the integrity is going down? So similar to a raisin that develops following a grape. The more complex it gets, the more damage or change in its original integrity, one would conclude. So third, we really wanted to see if the techniques we developed could be of value in NMOSD, and we focus on the area postrema because it ranks number 2, maybe a tad bit higher in terms of aquaporin 4-channel presence or bulk. And so we used a given curvature metric at the region of the area postrema near the clava and studied the characteristics from there by looking at the types of triangles that were present based on if it were concave or convex, or what we call interplanar contouring, or the given spread of the triangles, the spatial dissemination pattern of those triangles on that surface. And so it was a retrospective investigation. And what we did was we looked at all the MRI scans that a person had when they're hospitalized, and then just blindly processed their MRI scans to see what we could get. And we compared it to another group of individuals, a dozen, who had a variety of disorders: genetically confirmed CADASIL, metachromatic leukodystrophy, limbic encephalitis, etc. And of course, a group of people with multiple sclerosis, 100. All the tests that we perform at UT Southwestern are sent to Mayo Clinic labs. So everyone gets a live cell-based assay. And that's been really history for us in our field. So here you see the region of the area postrema. You can see the area postrema here in this drawing. The gracile nucleus, gracile fasciculus, the fourth ventricle, the ependymal layer. So really what we're looking at is the area postrema here in blue. And one of the first things you see is that there's a different spatial distribution of triangles. So a triangle is not inverted, it's not concave or convex. A triangle can be that if you apply math to it and it's based upon neighboring triangles or triangles that are touching it. So blue is what we call an introverted planar contour. Think about a concave surface that you see based on neighboring triangles. And there's really a big difference between that and what you see in multiple sclerosis. And we didn't publish this part, but I'll throw it in because we looked at people with MOGAD and interestingly found almost a similar spatial distribution pattern that was craniocaudal at the region of the dorsal medulla as well. Here are data that look at the cross-sectional measures. So we actually looked cross-sectionally at how many blue triangles were present, and was there a difference between those with who are AQP4 positive or negative in comparison to all the other groups. And then, of course, how those values changed over time. And in NMOSD, those blue triangles tend to be more stable. For multiple sclerosis, they change much more dynamically. And there are reasons for that in our subsequent work that we eventually identified. So at UT Southwestern, we have a number of people with NMOSD, and we looked at every single person that has had an AQP4 test, every single person with NMOSD based on medical records, and arrived at this sensitivity, specificity, positive and negative predictive values. And just to put into context in terms of what we identified based on given triangle cutoffs, it was fairly comparable. And so we're involved in a study now to really offer this technique to healthcare providers, even if they're not looking for NMOSD, to process scans that come from our inpatient setting to allow for this measure to be given to people so that they can have some thought as to, oh, I should be considering perhaps a water channel disorder in this setting and not something else. So we did actually publish this, and I would say that it was probably the quickest process I've ever experienced in the past 20 years. So from the time it was submitted to the time that it was accepted, it was about a week, which we're really happy about. We're also looking at the time change. So looking at how these triangles and other measures change over time in the setting of disease stability or perceived disease stability, as well as progression as well. And this is a subject, a given person with NMOSD who ultimately died at around 2022 here. So there's a lot of benefits. We want this thing to essentially be free for people. And it can really, because it's automated, it can really be, the results can be provided to the healthcare providers really in minutes. And you don't have to wait for the result of the serological study. It's not aimed to replace that. That's always going to be the gold standard, but it's great to allow for another piece of data to return so that perhaps a given change in a treatment plan or education can be provided to people. So last couple of minutes, and this is just really brief, our future opportunities for this work. So we've been involved in a number of phase trials, thankfully. So we've had the opportunity of incorporating this technology into a number of phase trials. I think that our work involving individuals is interesting. I think we're going to be learning more about really how dynamic these lesions are over time. We have data that extend out to 10 years. We just haven't reported on it yet. And we have next generation 3D conformational work that involves other quantitative measures that can be easily acquired through a given clinical scan. So our goal is to really allow for this to be disseminated in regions where AQP4 testing is limited. And that even happens here in East Texas. And there are hospitals, and I've spoken to hospital administrators that tell me that the ELISA is what they do because it's a cheaper test. And, we're wanting to offer some of what we do really at no cost to allow for healthcare improvement. So we're also looking at dynamic changes. So really lesion dynamics, and with that, changes in shape, alterations in deformation, how lesions displace, and how does that inform on subsequent T1 hypointensities. The world is artificial intelligence, and I would say that we were involved in it, really before it came, I won't say mainstream. I think on Wall Street, it has just fairly recently over the past few years. And then this year, things have really blossomed, especially with NVIDIA and what's planned with Meta, et cetera. We'll even partner with Apple for some of our future work as well, just because there's an opportunity for us to leverage what's available in Vision Pro to allow for people to see dynamic changes in a different way. So just some final thoughts. Our eyes constantly deceive us, and we see really what we want to see. We see in a way that is, or that was beneficial for us in the past, and we constantly change, and we constantly redefine what is normal around us based on what's in our environment. We like to develop things that don't disrupt clinical practice patterns. We think we can get greater adoption that way. So I think taking what we have that may enable us to more effectively educate someone, that allows us to add color filters so that people can appreciate lesions better. To learn these things, I think are, and to discover these things, I think are really exciting. And, I think that the future will change. I don't think that we'll be looking at boring, static, colorless images, no matter what field you're in. And I think that there's still a lot more growth that can happen using similar technologies for other disease states. So just a wealth of people for me to thank, and this dates back historically to our early days in our conformational work. And some of these people have come and gone, but I still like to really highlight their names and their contribution for the success that we've had. All right, thank you. Thank you so much for your attention.
Thank you very much, Professor Okuda, for that brilliant, innovative talk. Is there any question to Professor Okuda from the audience? Yes, please.
Hi, Darin. This is Kazuo. Well, thank you so much for the inspiring talk. I've always been impressed by your pioneering work. My question is about slowly expanding lesion that covered by Daniel Ontaneda. He told us that slowly expanding lesion should be the one with centrality, so that the lesions with focal expansion should not be counted as slowly expanding lesion. By applying your three-dimensional analysis, is it really the case, or are some slowly expanding lesions may show a focal expansion, as a matter of fact?
So it's the one thing I'll tell you based on experience is that the application of the slowly expanding procedure will be very difficult to execute effectively within a phase trial. And the reason being is that lesions are just so very dynamic. And the construct of a slowly expanding lesion is something that evolved out of an imaging lab, right? So they are creating a definition of concentric growth that's seen on T2 that leads to some reflective T1 change. In real life, it is very, lesions change in a very dynamic way. And part of the reason why that metric may fail is that there is displacement from the original lesion position. So unless you have this really consistent growth, which may or may not be very common depending on who you want to ask and what opinion you want to get, lesions tend to be more heterogeneous than homogeneous in growth that way. So it remains a challenge. I think that perhaps the way we should be looking at it is any change at all, but it exceeds a given threshold that has meaning with respect to future pathology. Great to see you, Cosmo.
Okay, thank you. Thank you again.
There's another question, yes.
Hi, Giancarlo. Also, I have to congratulate for such a provocative, in some way, talk. Because you showed that there is much more dynamic changes that we have been used to think about in multiple sclerosis. Then my question is, if you had the opportunity to see if the dynamic of the changes, they take, let's say, some different behavior in a single person, so that the expansion takes place in parallel in many lesions, and then maybe the patient enters a phase where there is any more expansion, everything is quiet. So it's more than lesion-based on patient-based what we see. Because this is a very fundamental question. Looking at trying to compare the dynamic of MRI activity in the brain with the MRI and in the optic nerve with the OCT, we have seen some parallel behavior. So that's the reason of my question.
Great to see you, Giancarlo. It's from an individual to individual standpoint, it is very heterogeneous. I will tell you, to the point where the statement, "The more I've been involved in MS, the less I feel I know," resonates. I think one part I want to make mention of too is that what is the influence and contribution of brain volume, thalamic volume changes, etc., with all of this? And we've actually done it both ways, in-house methods, and then we've partnered with icometrics to see what their outputs also tell us. And we know that there's some degree of contribution when the brain parenchyma changes, or whole brain volume changes over time. But still, there are situations in which brain volume can change and lesion behavior and movement goes in different directions. So the brain volume change alone cannot explain what we're actually seeing. Some of the data I wanted to show tonight as well that has not yet been published is when we look at the brain stem and the upper cervical spinal cord. Interestingly, when changes do occur, the dorsal aspect seems to be most susceptible to injury. And perhaps it's evolutionary. We take on threats face on, and the dorsal aspect of our brain stem may be most vulnerable to injury. Of course, we see this with NMOSD, and of course, the ventral pons and the ventral aspect of the medulla is very hardy. Giancarlo, more questions than not. I think I think how we approach defining success or failure for patients maybe needs to change. I'd like to see a change in clinical trials as well to allow for these other measures that tell us the other side and not just what has expanded. And I think there needs to be uniformity as well in terms of our definitions for newly enlarging lesions, because every single manufacturer has their own definition. But going back to the concept of slowly expanding lesions, it is a great one, and it's one where it does inform on future disease activity. But personally, I don't believe that it's all-encompassing. I don't think it represents the vast majority of lesions that we see, and perhaps those may be the ones that may be the key drivers as well to all of this, and not just the slowly expanding lesions.
Okay. Thank you, Dr. Okuda, for that very interesting presentation. Now we move on to the final presentation of the symposium. Our speaker is Dr. Amila Chandrakumara, who is a consultant neuroradiologist at National Hospital, Colombo. He is going to speak to us on the utility of MRI in differentiating mimics of demyelinating disorders. Over to you.
Thank you, Kishan. Thank you, Kishan, for that kind introduction. And yeah, after a lot of super informative talks and lectures about MS, NMOSD, MOGADs, this topic is about not about the those, but about their mimics. And since the mimics are quite extensive, I'm going to discuss a handful of common mimics, how to spot a mimic, and if time permits, a couple of cases. So going to introduction, we all know magnetic resonance imaging has become an important tool for the diagnosis of demyelinating disorders. The knowledge of characteristic lesion morphology on an MRI allowed clinicians to scrutinize the diagnosis. It is also equally important to recognize other CNS disorders in which the lesions are similar in morphology, commonly known as demyelinating mimics. There are over 100 disorders that can mimic demyelination. The differential diagnosis includes entities that ultimately lead to demyelination, but they're caused by other pathologies such as vascular, infectious, genetic, metabolic granulomatous, and other immune-mediated conditions. In a MRI, what we look for is an abnormal T2 flare, high signal focus. So the most common mimics are benign conditions, such as migraines, psychogenic or UBOs, as you already know. If we consider normal population, since there are more people in a population with these normal findings, in day-to-day practice, what we mostly see are these conditions. Thinking of that, before going further, I would like to emphasize this image, which simplified and summarizes the typical lesion locations and number and size of variations on inflammatory disorders. And you can see multiple sclerosis. They are usually anterior one optic nerve short segment lesions. In the spinal cord, the cervical and dorsal spine are involved, with the cross-sectional imaging shows not much of a edema and very short peripherally located lesions. Typical dozen finger kind of lesions in the brain. And you can see there's involvement of the cortex and involvement of subcortical U fibers. And brainstem lesions are in the cerebral hemispheres and middle cerebral peduncles. If you look at the MOG positive cases, they are also more anterior located optic neuritis, but they are also long segment involvement. And the spinal cord, usually you get the conus and lower spinal cord is the involved and represents a long extensive demyelinating kind of lesion. And in spinal cord, they are very large lesions. Transversely also, they are extensive lesions. And usually they don't involve the supratentorial compartment, usually infratentorial lesions, which are quite larger and involve the pons and the brainstem. Going into the NMOSD AQP4 positive patients, the lesions, again, the optic nerve involvement is quite posterior than the other two groups, and involves the optic chiasm and also the optic tracts. Lesions, spinal cord lesions, similar to, but different to MOG, they are involved more dorsal spinal cord lesions, and there is a lot of edema. They are kind of LETM lesions. And going into the brain lesions, since AQP4 water channels distributed throughout usually around the ventricles, the distribution is lesions is around ventricles, basically. So you can see around ventricles and ventricular margins. These are the where lesions typically occur. But for some reason, there are lesions occurring in the internal capsules, posterior on the internal capsule area. And sometimes they produce a kind of trident kind of appearance on MRI. So just remember this image, because what we day-to-day see is we kind of look at these images and we look for abnormalities. So these are few images, contrast enhanced images. This is the other modality we use. We use contrast images to differentiate the mimics. So these are, this image shows the complete peripheral enhancement, and this is quite smooth. And this kind of appearance we usually get in lymphomas and HIV kind of patients, and there's another lesion there. And the other lesion shows, again, a complete rim of enhancement with irregular margin, irregular inner margin. And this kind of appearance with some edema this kind of appearance is typically found in like kind of high-grade malignancies like GBM. And this image is quite interesting. There's a complete ring of enhancement, but you can see a thin ring within the ventricular side of the lesion. The rim is quite thin at the ventricular side compared to the cortical side. And this is kind of typical appearance of an abscess. The other image is where the peripheral enhancement, quite large lesion, but there's a peripheral enhancement with cortical side incompletion, kind of here. There's slight incomplete, and here. So cortical side, in the incompleteness, we are quite characteristic for the demyelination lesions. So these are what we look at. And so chronic white matter hyperintensities, this is one we see quite often. Risk factors are increasing age, hypertension, and diabetes. Lesions are usually bilateral and relatively asymmetrical, mainly distributed in the frontal and parietal lobes, less in temporal lobes. Deep white matter changes are there. Corpus callosum usually not involved. So there may be background old or acute lacunar infarctions and hemorrhages. There are no spinal cord lesions. Sometimes you can see central pontine lesions. And this is so other important thing is migraine. Migraine, usually unilateral headaches and present with autonomic dysfunction. About 40 to 50% of patients demonstrate T2 hyperintensities in the white matter of the central semiovale. They are quite similar to small vessel deep white matter ischemic changes, but they are in a different age group, and they are early mid-adulthood compared to the previously discussed patients, and much more common in females than males. And additionally, there may be increased T2 signal in the cortex, overlying the white matter abnormalities as well as in the brain stem. The other mimic we should be aware of is CNS vasculitis. CNS vasculitis represents inflammation of the blood vessel walls. Could be primary or secondary. Primary usually confined to the CNS with no involvement of the other systems, referred to as primary angiitis of the CNS. Secondary CNS vasculitis occurs in the context of a systemic inflammatory or infectious process. They usually have other features like fever, night sweats, TIAs, thunderclap headaches, and involvement of paranasal sinuses. Sometimes you can see if you look at the sinuses or nasal septum may be eroded, kind of appearance in these patients. And infarctions, hemorrhages, and arterial stenosis can be seen on MRA. So lesions involve either subcortical white matter, cortical gray matter, deep gray matter, and deep white matter. This is a patient which shows bilateral. This is a FLAIR image, and this is a diffusion weighted image. There are bilateral frontal and left high parietal multifocal regions. You can see and frontal lobes, and in the parietal lobe, diffusion restriction involved in the cerebral cortex, gray and white matter interface consisting with, since there's a diffusion restriction and involved with the cortex, they are kind of consistent with small infarcts. But when we go through the MRA, there are multifocal segmental narrowings, both small and medium-sized vessels. So there is some typical beaded appearance of the middle cerebral artery, you can see here, and some stenotic segments in all the posterior cerebral arteries as well. And this image is quite important. We do vessel wall imaging. This is a black blood vessel wall imaging image where we contrast and see the enhancement of the vessel wall. And it demonstrates vessel wall enhancement. So this is vessel wall enhancement with multiple regions there as well. So this is kind of consistent with vasculitis, with vessel wall enhancement. And the other important pathology is the Susak syndrome, which is mimica. And this is immune-mediated occlusive microendotheliopathy. So clinical features are, they usually present with a multiple stroke-like episode, multiple strokes. And females are more affected than males. Kind of these are kind of most affected patients are females. They are present with the clinical triad of headache, encephalopathy, sensorineural hearing loss, and vision abnormalities. So imaging-wise, what we see is T2 flare white matter hyperintensities, which is present in more than 90% of patients. The characteristic is the involvement of the corpus callosum, where the corpus callosum involvement in a white matter normal in a stroke patient is quite unusual. And there may be some basal ganglia lesions, and there is a variable enhancement. So these corpus callosal lesions are like snowball kind of lesions. You can see these lesions. They are in the center of the corpus callosum, not in we know no characteristic lesions in the MS is calloseptal interface, but these lesions are not in the calloseptal interface. They are at the center of the corpus callosum usually, and there are maybe some lesions in the periventricular white matter lesions. So they are diffusion restriction because they are infarcts, and so important thing is involvement of the center of the corpus callosum and not affecting the calloseptal interface. So this sagittal T1 image shows the characteristic involvement of the splenium of the corpus callosum, the center of the splenium, and also body of the corpus callosum. Other important one is CADASIL. CADASIL is autosomal dominant disorder, and there is a missed Notch3 gene mutation. There are characterized by pathologically, there are granule deposition in the small arteries and arterioles. There is arterial thickening and stenosis. There is occlusion and white matter rarefaction. Usually they are present with heritable, this is the most common monogenic heritable cause of stroke and vascular dementia. Recurrent ischemic strokes in a young and middle-aged adults, we should suspect the CADASIL. And identified risk factors are usually absent because these patients, young patients, no history of hypertension, and they have some 35% have first degree relative of, with known CADASIL. On imaging wise, imaging abnormality usually precedes at least 10 years before the overt symptoms. They are usually multiple lacunes. Involve the basal ganglia, subcortical white matter, thalami, and brainstem. T2 flare heritable intensities are seen in patchy confluent areas. Important thing here is the involvement of the anterior temporal lobes and external capsule, which is quite sensitive and specific. So these flare images shows the involvement of the appearance of a patient, and shows the temporal lobe involvement and the external capsule involvement with white matter high signal intensities. The other condition we should be aware is neurosarcoid. Neurosarcoid is seen in about 5% of patients with sarcoidosis involving both central and peripheral nervous systems. There is cranial neuropathy, especially involving the optic nerve and facial nerve. When the hypothalamus and pituitary are involved, neuroendocrine manifestations do occur. There may be myelopathic symptoms. Signs of meningitis, encephalitis from pachymeningeal or leptomeningeal enhancement is there. And inflammatory peripheral neuropathy resembling Guillain-Barré syndrome is sometimes can be seen. So neuroimaging, we will see enhancement of different structures. There's enhancement of the parenchyma, there's enhancement of the meninges, both leptomeninges and pachymeninges, and there may be involvement of the pituitary gland, which and the infundibulum. Then patient may go into develop endocrine disorders, and then there is a extension of the inflammation or enhancement along the cranial nerves, and so it is important to mention here the optic neuritis in sarcoidosis. It's quite difficult to indistinguishable from the that of MS. So ventriculomegaly caused by hydrocephalus. So there are spinal cord lesions. So I will go in the next slide. So this is a pre-contrast and post-contrast image. T1 weighted fat saturated image shows enhancing lesion in the posterior medulla. And there is also enhancement of the leptomeninges and also enhancement of the hypoglossal nerve. So, and these are again images, T1, T2 images, shows the the high signal lesion, and again the medulla. And this image shows the glossopharyngeal nerve, which is thickened, not in this side, but this side it's a bit thickened, so nerve thickening. And the characteristic feature we often see is the enhancement of the pachymeninges. You can see. So, regarding spinal cord lesions do occur in the sarcoidosis. So this lesion looks like a longitudinal lesion, and after giving contrast, you can see an enhancing lesion, which is the enhancement is broad-based over the surface of the cord. So this is not the typical enhancement we see in demyelination disorders, and there is a broad base to the surface of the cord, and there is also enhancement of the pyometer. Sorry. Oops. Yeah. The next very rare clinical, very rare the disorder is Clippers. This is called chronic lymphocytic inflammation with pontine perivascular enhancement, which is responsive to steroids. There are very few diagnostic cases. They are present with punctate curvilinear. The important word is peppered kind of enhancement pattern within the brainstem, which usually involve the pons. And so this is so these enhancing lesions can spread to the spinal cord and brain. So this is contrast, and contrast with both are contrast images show this typical peppered kind of enhancement involving usually characteristically the pons, but can involve both supratentorial and also the spinal cord. So this is a small case. This is a middle-aged man presented with a 2-month history of progressive severe left more than right leg weakness and confusion. He had history of intermittent weakness of either arm for 1.5 years duration, and initially suspected to having multiple sclerosis. His initial MRI of brain and cervical spine was normal, which is done about a year ago, and further questioning reveals some weight loss over several months. So these are the investigations. Important things are ESR22, there's which mildly elevated protein and high albumin index. So this is the MRI images, FLAIR image, which shows confluent kind of hyperintensities in both cerebral hemispheres. This is not involve the subcortical U fibers, and there are some lesions show diffusion restriction, some do not, and these are ADC maps and diffusion weighted images. Contrast images show some enhancement, very patchy enhancement. MRA appears normal, no features to suggest vasculitis. So what is your differential diagnosis? So this patient ultimately went for a biopsy, and biopsy reveals intravascular CNS B cell type lymphoma with occlusion of parenchymal and leptomeningeal vessels. So CNS lymphoma is the other mimicker, and there are primary CNS lymphomas and secondary CNS lymphomas. Primary CNS lymphoma, there's no systemic involvement. It's a primary brain involvement. Occur usually in immunocompromised patients, elderly, and usually the appearance is brain mass kind of appearance, and there may be cranial nerve involvement, leptomeningeal and spinal cord involvement. Whereas the secondary CNS lymphoma can have a mimic MS kind of appearance, which we look at this patient, where there are multiple white matter lesions, patchy white matter lesions. They are usually rapidly progressive and sometimes fatal. Then other important diagnosis we should consider is Machafavia-Bignami disease. This is disorder characterized, this is the deficiency of, this usually present in patients with alcoholics, usually due to deficiency of thiamine, and neurologic manifestations include dementia, dysarthria and aphasia, hemiparesis, ataxia or apraxia. The characteristic lesion is in the corpus callosum, which is classically involved and may appear edematous in the acute phase and atrophied in the chronic phase. It typically starts in the body during the initial stages of the disease and later spread anterior into the genu and posterior into the splenium of the corpus callosum. So this is images taken from a book from a 58-year-old man with chronic alcoholism, drinking a bottle of wine for more than 20 years, is presenting with progressive memory decline and gaze instability. And there are flare images, the axial and sagittal, show T2 hyperintensities involving the corpus callosum, which is slightly edematous, and there is a diffusion restriction. So this is the characteristic appearance, which is kind of, it suggests this is a cytotoxic edema developing in these patients, and this is the appearance of Marchafavia bignami. So in one of the corpus callosum, in an alcoholic patient, which is kind of a history, very progressive history, you should suspect Marchafavia bignami. And another important diagnosis is PML. PML is a rare opportunistic infection caused by the JC virus, and they usually present with altered mental status, motor deficits, limb and gait ataxia, and visual symptoms. And it is important the appearance of a brain images depending on the immunity of the patients. Usually they are immune compromised patients, but depending on the immunity or treatment of the patient. And usually what mimics is this Milky Way-like appearing lesions. They are usually bilateral but asymmetrical. There may be corticospinal tract involvement. And the important thing is these patients, if you look at the subcortical U fibers, are usually involved. So in PML lesions, usually subcortical U fibers are involved. And there are certain signs, the typical Milky Way sign is there. There are some called barbell sign and shrimp sign, and these depending on the immunity of the patient. And other important, now going to the spinal cord, other important thing we should consider is subacute combined degeneration of the spinal cord. This is a neurological complication of vitamin B12 deficiency that predominantly affect the dorsal and lateral portions of the spinal cord. This is very well can mimic long extensive transverse myelitis lesion, and the patients usually presented with vibration and proprioception loss and gait ataxias and distal muscle weaknesses, ultimately leading to dementia. And this is images T2 stare and ADC. So this is a diffusion ADC, and axial T2 weighted image shows that there's a characteristic. Even you can see the lesion there is expansion of the cord, there is edema, but the classically lesion involves the posterior aspect of the cord. And in MR axial sections, we can appreciate it's like an inverted V shape, and this characteristic appearance can differentiate it from the demyelinating disorder, the inflammatory demyelinating disorder. And there is usually there is no contrast enhancement in these lesions. Other important kind of neurosurgical or neurointerventional differential diagnosis is spinal cord arteriovenous shunts or fistulas. Arteriovenous shunts may cause indirect and direct effects on the spinal cord, such as congestive myelopathy, intermedullary hemorrhage, and clinical syndrome. There is clinical syndromes which characterize there is subacute neurological deterioration due to congestive myopathy, may be seen in patients with arteriovenous shunts. So imaging wise, so what we see is longitudinal extensive transverse myelitis kind of pattern where there's a cord swelling, and I will show you the image. So this is the image, of T2 weighted image. The important thing, you can see cord edema and extensive transverse myelitis kind of lesion, quite extensive, and involve the more than half of the cord. But if you look carefully, you can see small flow voids in the posteriorly along the spinal cord. So these are perimedullary veins which are dilated because of the fistulation of blood. And to kind of confirm this, and for the treatment, patient should underwent a DSA, and DSA shows the site of fistulation and also dilated perimedullary veins. So another important presentation. This is another patient, a young patient with severe shock-like sensation and ultimately leading to paraplegia. And these are the initial MRI scan, which shows the cord expansion, and also there is the cord expansion and longitudinally extensive lesion. And the striking thing is this expansion is more situated anteriorly rather than posteriorly, and there is no enhancement. An axial T2 weighted image shows the anteriorly kind of owl-eye kind of appearance on MRI. I don't know whether you can appreciate it. There are two kind of lesions, and this is due to anterior spinal artery occlusion. So typical owl-eye snake-eye appearance, and there is a restricted diffusion. If you do a diffusion weighted imaging on the spine, we should have detected restricted diffusion. And small few review questions. So what do you think? What is the demyelination here, demyelination lesion? So this side, you can see the fairly asymmetric lesions, and here you can see a lacune. So this is ischemia and or lacunar infarcts. And this side, you can see typical periventricular lesions, lesion extending up to the ventricular margin, and they are perpendicular to the ventricular margin also. And this is a demyelinating lesion. And again, this is Susak's disease, where you can see lesions in the center of the corpus callosum, and these do not come up to the ventricular margin. So this is chronic microsclerosis, and this is typical MS lesion, where there is a caloroseptal interface lesions. And finally, this is demyelination, which is tumefactive. This is demyelination, which is tumefactive, and you can see incomplete ring enhancement. Here, there is a butterfly kind of lesion crossing the midline with avid enhancement. This is a lymphoma. So, and this is a glioblastoma with the internal irregular rim kind of enhancement. So you can differentiate depending on the enhancement. And a word about MRS. MRS, especially the kind of long TE images where we usually use, show both high-grade gliomas, both low-grade gliomas, and the kind of tumefactive demyelinating lesions, TDLs, show increased kind of Na to choline ratio, choline to Na ratio. So you can see this is demyelinating lesions. The choline to, if you look at the peak, the choline peak is, the Na peak is quite larger than the Na peak on kind of a high-grade glioma. So this sometimes can be useful, but there are some cutoffs recommended. But these are kind of very difficult to differentiate the low-grade gliomas from tumefactive demyelinating lesions. Another thing is, if you do the short TE MRS, there maybe you can see some metabolites such as beta-gamma glutamine or glutamine in the tumefactive demyelinating lesions. So ultimately, so these are the key points. So many disorders, kind of more than 100 of disorders, can mimic demyelination on MRI. So it is important to look at the patient's history, whether there is an atypical presentation, and always should suspect this, because differentiating the demyelinating, the inflammatory demyelinating lesions from other disorders is important, because treatment is completely different. And so white spots in MRI due to migraines and white matter ischemia are much more common than demyelination. And although there are many mimics of demyelination, careful evaluation of the imaging with the knowledge of the distribution, location, and morphology of the lesion in conjunction with laboratory analysis will often guide to the correct diagnosis. So thank you very much.
Thank you, Dr. Chandrakumara, for that very thorough presentation. I would like to invite the audience for any questions.
Thanks, Amila, for that wonderful talk. How sensitive DWI and ADC images in the spinal cord detecting lesions or diagnosing conditions?
Yeah, it's quite sensitive. The thing is, most of the imaging the machines at the Sri Lanka are not equipped with the DWI, but here at NHSL we have one machine which are doing DWI, and it's quite it's quite sensitive.
Thank you, Amila, for that talk. Is there any feature that you can recommend for us to differentiate the white matter lesion in migraine from that of MS?
Yeah, thank you for that question. It is very difficult sometimes, and mostly we go with the history. Patients usually present with migrainous kind of episodes and then come to the scan for the patient, and we then do look whether the patient is kind of compatible with the McDonald criteria or for the MS. And these lesions usually small lesions. What we suspect is whether this is MS when you look at the images. And usually they don't show restricted diffusion. Usually they are there. If you follow up images, they don't show any increase in size. And so when you look at an image, if it is not typical MS kind of lesion where dorsal fingers and the subcortical U5 involvement and cortical involvement, it's quite difficult.
Thank you, Dr. Chandrakumara. I think from my personal experience, we do, for the initial question, we do diffusion-weighted imaging at Kandy as well. And we've recently diagnosed several cord infarcts in these patients, and the images have been very sensitive. The only thing is the technique is not very good in terms of spatial resolution. So although the images aren't as nice as typical T2 images, it is very sensitive. And in terms of migraine, it's the ischemic, the lesions that we see in migraine are typically in a ischemic pattern, because it's said to be due to the vasoconstriction phase of migraine. So if we'd see a history of headache with a more small vessel disease type of distribution, I would think that as more for migraine, whereas a demyelinating condition would probably be more, it would have like a perivenular distribution, and it might have juxtacortical lesions. So that those might be helpful in differentiating along with the history of headache. Thank you again, Dr. Chandrakumara, for your very thorough presentation. And with that, we come to the conclusion of our symposium on neuroradiology of demyelinating disease. The next item in the agenda is the tea break.
Break up for tea, and we'll be back in 20 minutes time because we are running behind the schedule.